Good morning, everyone. I'm in Washington, D.C., and it's still morning, and I think everyone else is west of here, so I think we're still all, or good morning appropriate. I'd like to welcome everyone to this listening session on behalf of the National Academies of Sciences, Engineering, and Medicine. I'm Dr. Ken Kaiser. I have the privilege of being the chair of this study committee on a fairer and more equitable, cost-effective, and transparent system of donor organ procurement, allocation, and distribution. I have the privilege of working with a number of excellent colleagues on this committee, and on behalf of all of them and the committee, I thank you for joining us and look forward to the discussion today. This study is officially sponsored by the National Institutes of Health, although that is pursuant to the Consolidated Appropriation Act of 2020, i.e. Congress asked for this to be done, and NIH was tasked with making it happen. And we are or this committee and the National Academies is the effector arm, if you will. The committee's task is to consider opportunities to create a fairer, more equitable, cost-effective, and transparent system of donor organ procurement, allocation, and distribution, as the name of the committee suggests. More specifically, among other things, we have been asked to identify gaps, barriers, and opportunities for improving deceased donor organ procurement, allocation, and organ distribution to waiting recipients at transplant centers. I underscore that because we are not, or the committee is not focused on living organ donations, but on deceased donor organ procurement and allocation distribution. We also have been asked to look at how there might be better alignment of the performance metrics or incentives of the various stakeholders within the organ procurement and allocation network, and also to develop recommendations to maximize public and professional trust in organ donation, procurement, allocation, and distribution processes. The goal of this particular public listening session is for the committee to receive comments from a range of perspectives about challenges and opportunities in the deceased donor organ system. This public session follows three previous open sessions where we've heard from a variety of experts and stakeholders in the organ transplant system in the US, as well as several other nations. Obviously, the committee has had a substantial number of other meetings in addition to these public open sessions. A few obligatory comments here about the rules of the road, if you will. This is an open, on the record session, and this is an information gathering session only. That means, in essence, that we, the committee, are still in the process of assembling and examining data, information, and materials to further consider as we move forward in developing conclusions, findings, and recommendations. And insofar as this is a listening session, we do not anticipate engaging in a discussion of the comments as they are made. Importantly, we have 37 individuals from different perspectives who are scheduled and who have stated that they will be making comments, which means that there is will be a limit on the amount of time available for those comments, as well as any clarifying questions. And I should probably, in case you're hearing the sirens in the background, my office is a couple of blocks away from the White House, and frequently we have lots of sirens and other noise in the background, so I apologize for that if that comes through. We, as I said, we lost my train of thought there, but as I said, because of the large number of speakers, we really will not be engaging in discussion, except for perhaps some clarifying questions if those arise. I would also be remiss if I didn't note that if there are questions by the committee members, that those should not be interpreted to mean anything of note. It is not unusual for committee members to ask probing questions that may not indicate any particular personal view of themselves or any view of the committee. I would ask that everyone today maintain the same rules of decorum that they would if they were at a traditional public meeting, and that again that they adhere to the strict limit of 5 minutes for comments. I do know that many of the speakers have submitted written comments that are more extensive than what will be presented in the oral comments, not unlike what happens at congressional hearings where you're limited to a few minutes to make oral comments, but written comments may be longer and go into more detail than what one is allowed to say in the allotted time. And I would also apologize up front that if one does go over the allotted time, we may cut you off out of respect for the other speakers who were also donating and giving their time today as well. So, and to help in that regard, staff will be posting a 2-minute warning, if you will, as well as 30 seconds so that folks have a chance to wind up their comments. And lastly, or next to last, we will be taking questions if folks do have questions, and should there be time, we will try to address those. If not, we will try to think about them and address them later after this meeting, and those can be posted in the chat box. And lastly, in the way of these introductory comments, I would note that written comments and more detailed comments are certainly welcome, and people should feel free to present such, and those can be sent by email to the committee email address, which is organstudy, one word, at nas.edu. Again, organstudy@nas.edu. I would also note that I've asked Rebecca to take over the chairing the committee from about 12:15 for roughly 10 minutes or so. Otherwise, I expect that I will be introducing the speakers as we go forward. And with that in mind, and I think I have expressed all the obligatory things we need to say this morning. Is there anything, Rebecca, that you want to add before we launch into the speakers?
No, thank you. Thanks to everyone.
Okay, so in this first session, we have scheduled 11 speakers that will come from a variety of backgrounds and will cover a variety of perspectives. And we're going to start with Donna Handy, who's a patient at the Massachusetts General Hospital. I will go in the order that they're listed. If someone is not here for whatever reason, when we get to them, we will circle back later to see if they've rejoined us. So, but with that, Donna, perhaps you could lead us off.
Hi, thank you. I'm Donna. I'm 40 years old. Last year, I was diagnosed with TSC and NASH, and I was listed on the liver transplant list in September of 2020. My doctors contacted me with an opportunity to share what they like to call my unique story. So I just wanted to speak about the Meld Score, and that in unique situations like mine, they might not be an accurate representation of just how ill a person is. For instance, my natural Meld score is a 15. I did get the exception points, which brings me to a 27. But I live in Rhode Island, so statistically in my region, for an organ offer, it's usually 30 or above. So the problem with this is that even though I am getting sicker, as evidenced by the number of hospital stays, increased number and frequency of procedures, these are not reflected in my Meld score. I actually did a little bit of math, and I figured out that in the last year, I spent 22% of the year actually inpatient at a hospital. This doesn't include all the time at home recovering. My current major problems are cholangitis and tip occlusion. I've had 6 hospitalizations in the last year due to these. Due to the frequency, I have 3 stents in my bile duct, so I have to have a procedure every 3 months to replace these. And unfortunately, I'm not even often making it to the 3-month mark before I get sick and end up in the hospital and having to have them replaced. The stent in my liver has become occluded. I've been placed on Coumadin, and it's still happening. 5 weeks ago, I was placed in the hospital. It was 100% occluded. They went in and fixed it. And then Friday, I had an ultrasound, and once again, it's occluded. So what does this mean for me? Another procedure. And the problem with that is risks. Twice with the TIPS procedure, I've ended up with sepsis and shock, my blood pressure plummeting and ending up in the ICU. Now, both of these situations will resolve once I get the liver transplant. However, once again, as it stands now, none of this is being taken into account to calculate the Meld score, which is supposed to depict an accurate representation of just how sick I am and my place on the list for transplant. And for quality of life, I've been going to get my master's degree in mental health counseling. I should have graduated in May, kind of coming up with an ethical dilemma, because how do I take on a caseload of clients knowing that I'm going to be MIA every few months, even if things stay status quo? I'm kind of stuck in this exhausting limbo. I'm not really well enough to actually live my life, but according to the Meld score, I'm not yet sick enough to move up the list and receive an organ offer. My doctors have applied 3 times for extra points, and I have been denied on all 3 occasions. So, in conclusion, I believe the results of the Meld score is not always an accurate representation of just how ill someone is. And in unique situations such as mine, looking at the person on a holistic level and not just the results of an equation, dependent solely upon the results of 4 blood tests, may lead to a fair and more equitable distribution of the organs. I mean, I'm certainly not an expert, and I don't have enough education or knowledge to come up with a direct answer on, how this could be accomplished. But I just wanted to share one patient's unique perspective and the idea that kind of this one-size-fits-all equation that's being used right now may not be the best solution. So thank you for your time and attention.
Thank you, Donna, and thank you for the courage of sharing your personal information with us. Appreciate it very much. Next, Ashley Helsing.
Thanks so much. Hi, everyone. My name is Ashley Helsing, and I am Director of Government Relations at the National Down Syndrome Society. We are the leading human rights organization for all individuals with Down syndrome. I am honored to speak to you, the most elite group of medical experts in the United States today. I want to ask for your help and your leadership in ensuring equity of care for vulnerable populations. I'm here today to ensure you are aware of a crisis in the Down syndrome and wider disability community, organ transplant discrimination. The National Down Syndrome Society has been working on this issue legislatively for a number of years. We've worked to pass legislation banning organ transplant discrimination and have thankfully been successful in 26 states as of a couple of weeks ago. We now have federal legislation on the books called the Charlotte Woodward Organ Transplant Discrimination Prohibition Act, HR 1235, which was introduced by Congresswoman Jamie Herrera Butler and Congresswoman Katie Porter. You will hear from Charlotte herself soon, but to summarize, this important legislation upholds legislation that is already on the books, like the Americans with Disabilities Act and Section 504 of the Rehabilitation Act, that say you can't discriminate against people with disabilities for medical procedures. Unfortunately, we know that it is still happening. How do we know? A few ways. A survey of 88 transplant centers conducted by researchers at Stanford found that 85% of pediatric transplant centers consider intellectual or developmental disability as a factor in their determination of transplant eligibility at least some of the time. Additionally, 71% of heart programs surveyed always or usually considered an IDD diagnosis when deciding eligibility for a transplant. Another study shows that only 52% of people with IDD receive a referral for a specialist evaluation, and 33% of those who are referred are never even evaluated. What makes these startling numbers matter, though, are the stories. Take Kathleen in Texas. For 12 years, her parents performed catheters every 4 hours on her brother, Daniel, who had Down syndrome. 12 years. He died of kidney failure in April of 2015. A transplant was never even presented to him as an option by his doctors. Also, James in California, who has Down syndrome and autism. In 2017, James, with 12% kidney function, was told by his doctor that his IQ was too low for a transplant. Also, Nikki, a single mom in Minnesota. Bryce, her teenage nonverbal son with autism, was in liver failure a couple of years ago. He and his family were told by their doctor that he would not bring as much value to the world as someone who is typically developing, so he wouldn't be able to get a transplant. How would you feel if someone, a doctor for that matter, said that about your son or your daughter or loved one? Similarly, how would you feel if someone, again, a doctor, didn't tell you about all of the options available to your loved one? James and Bryce thankfully received their transplants and are now thriving after their loved ones advocated nonstop for their lives. But how many stories do we not know about? You will hear Charlotte's story soon, and you should be very excited because her story is incredible. But why is it so incredible? Her doctors knew that she needed a heart transplant and they acted on it. But we need your help. We need everyone's help to finish passing these bills, and we need you to do something about doctors who continue to not value the lives of people with disabilities. Please help us with recommendations to Congress, the administration, and other medical leaders to support decision-making that is focused on access to care for individuals with Down syndrome and other disabilities who need transplants on a case-by-case basis like all other individuals. We are just asking for equity here. Thank you so much for your time and attention to this important issue.
Thank you, Ashley. Appreciate that. Next is Robert Higgins.
Good morning. Thank you for the opportunity to join you today. I hope to speak to the need to continue the system which is currently evolving to address the important needs of patients like Donna and Ashley and others who represent those who are in need of life-saving and life-enhancing organ transplants. I've been an active transplant surgeon and administrative leader for the past 28 years, and I've been fortunate to partner with many of the folks on this session to address healthcare disparities in organ procurement and allocation. The system, I believe, adapts its policies and practices and ultimately modifies and adapts to address health inequities that we see over the past 20 to 30 years. It's not a perfect system. It's obvious that there's so much work to do. As a former president of UNOS in 2009 and a practicing heart and lung transplant surgeon, I've helped to build much of the early efforts to increase the number of patients on the wait list who get successfully transplanted. I do think the system has changed to prioritize the sickest patients with the goal of reducing waitlist mortality. As an example, 2018, the new heart allocation criteria better accounted for the severity of illness on the wait list by implementing a new multi-tier system, prioritizing patients with the greatest chance of death while awaiting transplant. This is the greatest need. This system also expanded the geographical range from the site of donor hospital in an effort to prioritize available organs based on illness severity rather than geography, an important improvement. So while the new allocation system in hearts has resulted in new management strategies, its impact on early postoperative outcomes awaits further analysis. I think the broader question is ongoing challenges in policies like these hopefully will level the playing field and eliminate structural barriers like access to evaluation for end organ failure, or access to advanced therapies, or access to the waiting list, which in my opinion are the key entry points to the life-saving value of organ transplantation. Better organ allocation and distribution can only benefit patients who are being cared for and evaluated for end organ failure. So I believe that others on this session can speak to ways to improve waitlist management and post-transplant care, which will also be critically important to better long-term outcomes, better quality of life, and better patient satisfaction. We're encouraged to see that the organ procurement and transplant community has recently been held to new minimum quality metrics in order to receive Medicare and Medicaid payment. And these long overdue expectations, which hold OPOs accountable for seeking and transplanting as many organs as possible, will become a reality. The new measures, including the number of organs an OPO has procured from eligible donors in its donor service area, and the organ transplant rate measure will make a difference. But we're still aware that the current...
Dr. Higgins, could I ask you to wind things up?
So I think that ultimately new policies need to adapt. And as we heard by the residents and the patients on the call, that we need to do more to help eliminate disparities. So with that, I'll say thank you and appreciate the opportunity to comment.
All right, thank you for your comments. Kelly Israel.
Hello, can you see me?
Yes, you're fine.
All right. First, I want to thank the National Academies for inviting me to speak today. In the context of fair allocation of scarce medical resources, the voice of self-advocates and people with disabilities is critically important. As you're probably aware from my bio, ASAN's members and constituents are primarily people with intellectual and developmental disabilities. And unfortunately for us, as a previous speaker has noted, people with IDD have both historically and currently experienced significant barriers to obtaining life-saving organ transplants. Many of these barriers, they don't relate to the actual allocation system. They relate to the discriminatory attitudes of the medical providers that manage organ transplant centers and clinics, rather than to any specific aspect of priority setting by UNOS or OPTN or on organ transplant waitlists. In short, they apply at the evaluation stage and within the highly opaque context of decision-making about which patients to recommend for transplant and placement on a waiting list. This fact makes these barriers harder to address without direct outreach to and education for medical professionals. Although some states have laws which prohibit the practice, and a greater number of states are moving to create laws of their own, Charlotte Woodward can speak to that. Some transplant centers still determine that a person with IDD does not qualify for an organ transplant solely because they have IDD. IDD meaning intellectual and developmental disabilities. Many of these medical practitioners believe without evidence that people with IDD have a worse quality of life than people without ID. In other cases, the Organ Transplant Center may believe that people with IDD have worse outcomes from transplant than people without IDD, even though there is only limited evidence that any IDD impacts transplant outcomes either positively or negatively, and we're talking about life-saving resources. So sometimes this situation can be kind of opaque, and the person may not realize exactly what is happening. For example, a young adolescent named Leaf, autistic, who types to communicate, was told that no facility would perform the transplant on him, and that the family should prepare for him to die. Additionally, the doctors also failed to recommend bridge therapies for Leaf, which would help him survive until someone would transplant the organ, and no reason was given for any of this. Other times, it's very explicit. For example, Amanda Rivera's parents were told that she would never receive a transplant solely on the basis of her intellectual disability. An even greater number of transplant centers, while they do not mention IDD specifically, have policies and practices that treat the executive and adaptive functioning difficulties that are often present in people with IDD as contraindications to transplant. For example, many transplant centers have policies which list the inability to care for oneself without assistance, or the lack of a capacity to perform daily activities without assistance, both direct quotes from their websites as of 2019, as contraindications to transplant. Presumably, such policies exist because postoperative care is complex, and the Organ Transplant Center must be reassured that the organ will be attended to. However, many people with IDD have the support networks necessary to fully comply with postoperative care with assistance. And eligibility shouldn't be based on whether they can comply without it. That doesn't make any sense. So long as the decision-making of medical practitioners at the evaluation stage has little to no oversight or guidance applied to it, and so long as discriminatory attitudes exist, so too will these barriers to transplantation exist. We recommend that
Could I ask you to wind things up here?
Yeah, I'm finishing. We recommend that both the Department of Justice and HHS, in collaboration with UNOS and OPTN, craft guidance that makes it clear that disability rights don't cease to exist when you enter a hospital, and that the Americans with Disabilities Act still applies. Additionally, OPTN should ensure its own policies avoid discrimination. Healthcare practitioners are morally and legally obligated to evaluate patients objectively and without regard to disabilities unrelated to the need for a transplant or its success. Thank you.
Thank you. Appreciate those comments. Jamie Locke.
Good morning, everyone. I am both a transplant surgeon and a health disparities researcher at the University of Alabama at Birmingham. I'd like to just begin by drawing our attention to the differences between equality and equity. If you think about a dinner table, equality would imply that every individual has a seat at that dinner table, and equity would imply, or at least assume and understand, that not everyone that has a seat at the table comes with the same degree of nourishment, meaning some people may need more food in order to get to the same nourished state as others. Why is that relevant? Obviously, we want a system that is both equal and has equity. And I think the first step is that we need to really begin to break down silos. What do I mean? Well, if we really want to understand how to generate equity in our allocation, then we have to understand disease burden so that we can ensure that organs go to the areas with the highest level of need, which may have the lowest local source of organs. It's been often said, well, we can't do that. We don't capture that in UNOS data. Yet the federal government, for kidney, for example, does in fact capture that data through the United States Renal Data System. And so I think partnering with other entities across the government could help us actually address these questions. If you look at MELD and liver allocation, we need to also, beyond MELD, understand social determinants of health. For example, a Meld score of 21 in Appalachia is very different than a Meld score in 90210. in terms of access to healthcare and understanding the social determinants of health that increase those patients' disease burden and mortality and morbidity is critical. We have access to those data as well through something called the CDC Social Vulnerability Index, which already exists. And all of these data sources can be linked to UNOS data to answer these important questions. The second thing is we have to make our processes more nimble. I think everyone on this call, no matter who we represent, are all extremely good intentioned. But when we get it wrong, we just have to own it and do better. So let's take the model for end-stage liver disease that was introduced in 2002. Well, it introduced gender-based disparities in liver allocation. They've been present for 20 years and we've done nothing about it. Why is it? Well, it's because creatinine is included in the Meld Score. And we know that there are gender-based differences in the concentration of serum creatinine and how it correlates with underlying kidney function. So for any given Meld Score, for any given creatinine, a woman has worse kidney function than her male counterpart at the same creatinine level. So again, something that we could have addressed that we haven't. Let's take on geography. That is the latest thing that we're trying to tackle. I would agree that there are geographic disparities in allocation, but we probably looked at the wrong thing. It's not donor service areas or a 250 nautical mile circle that's the problem. We know that there are geographic disparities between transplant centers within DSAs. If you look at the island of Manhattan, there are geographic disparities that exist only 3 nautical miles apart. It's just the difference between transplant centers. And we know that patients' greatest probability of achieving a transplant is reflected in a transplant center's offer acceptance ratio, yet we've done nothing to hold transplant centers accountable. Instead, we've created a brand new allocation system that's increased the complexity, and we're spending thousands of dollars shipping organs all around. That brings me to the third. I think we have to have accountability in the funds that we spend. It drives me bananas that we don't spend a single dollar on helping the patient get where they need to go. Kelly outlined many patients that could absolutely be transplanted, but they might need more resources to be able to do all of the things that are necessary post-transplant to ensure good outcomes. That brings me to the fourth thing that we need to pay attention to, and that's implicit biases. Our previous speaker spoke to that. We need to have implicit bias training. Let me give you a couple of examples. Liver allocation, MELD-based. We know that the greatest disparity between men and women in achieving liver transplant is actually related to differences in size. So small women really struggle to actually get an organ offer accepted for them, and they often have organ turndowns. And data have shown that when you compare them to equally small men, they're still more likely to have an organ turned down. Why is that? Is it an implicit bias? Do people look at women and think they're more frail than men? We don't know. We've never studied it, and we've never had training in it. The same thing is true.
Dr. Locke, could you wind things up?
Yes, I'm almost done. The same thing is true with kidney related to obesity. Obese women are less likely to be listed than obese men. We need implicit bias training. And then finally, we don't need to be good at everything. OPOs should focus on finding donors, transplant centers should focus on transplanting people, and UNOS should focus on optimizing allocation. We need to partner with non-government entities to help us with things like logistics. So thank you very much. I appreciate the podium.
Thank you for your comments. Jerry McCauley?
Yes, thank you for allowing me to speak today. I'm going to limit my comments mostly to kidney and give a sense of my experience over the several decades that I was involved, both as a transplant nephrologist and as various committee members on UNOS committees. So there is a committee within UNOS called the Minority Affairs Committee. I'll say MAC after this. I believe Dr. Higgins was part of that group. And the charge to that committee is really to monitor and identify and help correct ethnic and racial disparities in transplantation. So this committee goes back all the way to the 1990s or so. Many of the policy changes relative to racial disparities actually have come initially from that committee. So just a brief historical view, back in the 1990s, UNOS was started in the late 80s. In the 1990s, it became very clear that there were disparities in access for African Americans to renal transplantation. And as a previous speaker noted, it took quite some time for us to address these and really to correct them. We made incremental changes. Most of those changes came from the Minority Affairs Committee. Initially, you may remember for kidney, tissue typing matching was a very important factor. Turns out that biologically and in terms of national policy, it was not that important. And the importance of tissue typing was minimized. We looked at things like, when do you start to accrue waiting time? And the waiting time start initially was when you completed your workup. And we know that patients who are socioeconomically disadvantaged take longer, so that the time they could have accrued, they didn't accrue. We suggested that we use start of dialysis as a uniform and biologically plausible way of determining what waiting time should be. That was also done. Also, the issue of sensitivity. We had a measure where you got no points until you got to 80% PRA, and that disadvantaged ethnic minorities. That was changed. So around 2015, a new CAS, we call it a new CAS, was installed, and that eliminated a lot of the healthcare disparities relative to race. And so we spent a fair amount of time studying that. And again, I perhaps we could get you some of these articles. These articles are clearly in the medical literature, and that actually details this whole story. As you heard earlier, that geography, we've eliminated DSAs and region, and now continuous distribution, at least for kidney and liver, has become an important issue. All of those measures, each policy change is vetted for disparity within UNOS. So as the policies are being developed, those policies are come to the MAC, and we get to look at whether or not there are obvious disparities. We don't look at everything. We look at race, we look at gender, and several others. We don't look at disability. At some point, perhaps we should do that. So these things are being vetted before the policy is rolled out. And we're probably industry leaders in at least monitoring for ethnic and racial disparities, because we do this at the front end. And if it's identified to be a large disparity, then that policy probably will not be enacted. Now, I'm not saying that everything is perfect. There is access to kidney transplantation before wait list. While they're on the wait list, we're trying to get rid of the race-based estimated GFR, and that should happen fairly soon. So that will be the end of my comments. Thank you for letting me speak.
All right, thank you, Dr. Pelly. Brian Shepard.
Thank you, Mr. Chairman, members of the committee. My name is Brian Shepard, and I'm the CEO of the United Network for Organ Sharing. UNOS is the nonprofit that serves as the organ procurement and transplant network under contract with HHS. Because we're responsible for the allocation of all deceased donor organs in the United States, UNOS is acutely attuned to issues of equity. UNOS works to ensure equitable policies and outcomes in multiple ways. As Dr. McCauley noted, committees of experts from professional and patient communities review the anticipated impact on equity of new policies before they're approved. And once they're implemented, routinely monitor data to ensure that the policies are having their intended effects and are not disadvantaging any candidates. We make transplant candidate and transplant outcome data transparent and publicly available so that outside researchers can examine trends and identify issues. And we maintain a publicly available equity dashboard on the data section of the OPTN website that highlights key outcome data by demographic categories. The equity dashboard allows the user to examine candidate access to transplant across multiple dimensions in a all else equal type of scenario. For example, the dashboard will tell you how much difference you might find in transplant rates among candidates who are identical except for where they live, or candidates who are identical except for their blood type or their gender or ethnicity, or whether they have public or private health insurance. The dashboard shows that inequities in access to transplant, once on the wait list, are small in all dimensions where they exist at all. And for all 4 of the organs that are on the dashboard, kidney, liver, heart, and lung, the single factor that has the most disparate impact on a patient's access to transplant is the area of the country in which they are listed. That's why we recently adopted proposals across all the organ types over the last few years to address geography, and we've begun to see reductions in geographic disparity as a result. A few years ago, as Dr. McCauley mentioned, the largest factor in kidney access was the sensitization level of the candidate. We adopted a policy change in 2015 to provide greater priority to those highly sensitized candidates and saw a reduction in variability of access. Those equity dashboards, committee reviews, and outside research, including Dr. Locke's, have pointed to inequities in lungs and livers for candidates of short stature, particularly of small women. And there's nothing intentional in the policy that creates that inequity, but disparate access can be arising partly because larger candidates can accept both larger and smaller organs, while smaller candidates can only accept the smaller ones, possibly because of the way the creatinine score is included in liver transplantation. To revise this, we can look at several options to revise the policy to create priority access and address that gender inequity. Again, one that developed as an unintended consequence of a policy that looks neutral and was reviewed only through this thorough data review, both that we do and that the transparency of the data allows outside researchers to do alongside us. It's important to keep in mind the organ allocation system can only provide equitable access to transplant candidates once they are on the waiting list. It is a fact that in the United States, access to healthcare in general is unequal. And there's nothing that the wait list can do to transplant a patient who does not have a transplant doctor. Access to health insurance must be addressed at the congressional level, and discrimination like that described by Ms. Helsing and Ms. Israel is not only immoral, but illegal in several states. And UNOS has supported the passage of those laws and supports a federal law to make it illegal across the United States. Finally, I'd be remiss if I didn't say that the ultimate form of equity that is UNOS's goal and the goal of the entire organ donation and transplant community is to provide a transplant for every single patient that needs one. The US organ donation and transplant system is the highest performing in the world, and the data prove it. We serve the greatest number of patients, recover the greatest number of organs from deceased donors, and perform the greatest number of transplants. Even adjusted for population, no other country in the world exceeds the United States. And that includes last year's pandemic, when the number of deceased donor organs donated in 2020 was a new all-time record, and that's the 10th consecutive year. In the first half of 2021, donation is up 15% over last year's record. Deceased donor transplants are also up, but by 11%, a reminder that solving the transplant wait list requires systemic solutions, and any solution that looks at only one part of the system is likely to be insufficient. I'm looking forward to hearing the comments in the later section about ideas to further increase the number of transplants, and urge the committee to keep in mind we are looking for continuous improvement of what is already the world's best donation and transplant system. Thank you.
Thank you, Brian. Next, Sweetheart, and forgive me if I botched your name.
No, that was pretty good. Thanks, Ken. Thank you for inviting me. I'm a professor of logistics and supply chain management. For 30 years, I have been dealing with supply-demand mismatches around the globe. And for those who don't know me from before, over 700 of the world's largest global companies in 50 countries use my software. So if you do find some shortages in your local target, it is a misuse of my software. I address 2 main issues in equity in access, geographic and gender, and I was so happy that several folks have already brought it up. And I would like to suggest a couple of operational techniques that I believe are easily implementable. Additionally, the first order problem of lack of supply can also be handled using what I find a zero cost solution that is immediately available, and I will mention that as well. Geographic disparity is so well documented, I don't want to spend any more time on that. Rather than send an organ to the patient, I decided why not take the patient to the organ. So I created an enterprise called Organjet, and here it's basically smart double listing with on-demand flight options. When there are direct commercial flights between the source and destination cities, there is no need for a private jet. In fact, most of the folks that have used Organjet have actually taken commercial flights. to get their kidney transplants, except maybe late at night when you might want a jet. Why is this possible? Even most of the candidates are actually in larger cities with good flight connections. Even if you don't have a commercial flight, there are 18,000 underutilized private jets in this country that can land in 5,500 airports with a 2-hour notice. Our research on Organjet has also shown that disparity can be largely reduced by just this double listing done smartly for less than 20% of the patients on the wait list. One of the recommendations I have is, since dialysis costs can be reduced by an earlier transplant, this could actually be a cost benefit to the payers, both private and public. So I urge the committee to look at smart double listing. There's a win-win situation for both patients and payers. Gender disparity in liver transplantation is related to the size mismatch, among other things, with the available organs correlated strongly against the height of the recipient. This has been mentioned just a couple of minutes ago. There is now 30% less chance for a woman to get transplanted compared to men. An easy fix, which was presented in ATC 2021 with collaborators from UCSF using LSAM, we found that providing additional exception points of just 1 or 2 to the shortest 8 to 10% on the list, male or female, will largely reduce this inequity without appreciable change to the rest of the population. This is so easy to implement that I would find it amazing that it would not be considered. Of course, the longer term possibility, some work that I've done with John Roberts, the previous head of UNOS, that you all know way better than I do, is to look at split liver transplants as a possibility, which is underused in the United States, but is used in other parts of the world, especially, I believe, in France. Finally, let me address the first order problem in transplantation, which is the lack of supply. First person consent rates have plateaued, and morbidly, one has to wait for such a person to die in a medically acceptable manner relatively quickly. This can hardly be considered an acceptable solution. Here's a much larger opportunity, is to look at the second person consent from legal next of kin. Our field experiment with Nevada Donor Network, thanks to Joe Ferrara and his colleagues, by using videos that are already freely available in English and Spanish from organdonor.gov, we have found that we can nudge those on the fence towards consenting. And we have shown that there's a significant increase in donation just by having people watch a video. I suggest that the committee look at OPOs, looking at already available videos in English and Spanish, and see if organ consent rates can be increased from the second person consent. Thank you so much for the opportunity to present. I look forward to hearing other comments and happy to take any questions when time permits. Thank you.
Thank you, Professor. Next, Fanny Vlahos.
Great, thank you. Good morning, my name is Fanny Vlahos. I was born with cystic fibrosis. I am 41 years old, and I'm a wife, community volunteer, I'm a licensed attorney, and most importantly, I'm a mother. I just celebrated my son's 10th birthday last week because of the gift of life. My baby was 4 months old when I was told I needed a transplant. In March of 2012, I was advised that if I didn't get a transplant, I wouldn't be able to spend the holidays with him. And just 2 months later, I received the call. I was pretty healthy most of my life. I led a pretty active life, and I was a healthy pregnant young woman with 130% lung function, and I went from that to lung transplant in 14 months. And so from my perspective, everything happened so very quickly, but the major stressor for me was by far insurance. And so I'm dealing with private insurance, and so I can speak to my experience with that. The very first step in organ procurement, allocation and distribution, is finding a hospital that will accept you and add you to their wait list. And so my coverage determined which doctor or program I could even consult with. And so when we talk about doctors kind of discriminating. You don't even get a chance to get in the door unless you're approved to see that program. So my cystic fibrosis center is 10 minutes away from my home, it's a reputable transplant center as well. But my insurance coverage did not allow me to get the transplant surgery there. They had a contract. My CF hospital didn't have a contract for the actual lung transplant surgery with my coverage. And so I was covered for pre-care, pre-op care, and post-op care, but not the actual surgery itself, which cost about $1 million. The next closest hospital that my insurance said, oh, you should go and check them out, was about 3 hours away. They did have a contract for the lung transplant surgery, but when I went and I met with one of their pulmonologists, she basically told me to enjoy what time I had left with my miracle baby because I was too sick and they wouldn't accept me into their program. So I ended up back at my local hospital only because they fought tooth and nail, only because of the personal relationships I had forged with that program, and they fought tooth and nail and advocated for me, and we worked it out. But after doing my research and inquiring and consulting with attorneys and the hospital administration and doctors, I came to find out that institution B was getting reimbursed at a significantly higher rate than other comparable programs. And that's because their survival rates were much higher. Now, does that mean they're a better transplant institution? So absolutely not. Their survival rates were much higher because they'd only accept the healthiest of patients. So from what I gathered, the way it works with private insurance is that hospitals have contracts with insurers for certain procedures at predetermined rates. And those rates have been calculated based on markers of patient success. So for example, institution B had a contract that reimbursed for 80% of the cost of the surgery because it had high rates of survival 1 and 2 and 5 years out, versus institution A might take higher risk patients and therefore their survival rates might not be as high. And so therefore they only get reimbursed 50% of the cost from the insurance coverage. And so the current system incentivizes hospitals to accept patients that they presume will make their statistics more favorable and therefore yield a higher rate of reimbursement from the private insurer, when in reality their numbers are skewed because they cherry pick the healthiest patients. And so decisions aren't made when you're dealing with private insurance. In my experience, decisions aren't made in the best interest of the patient, but what yields the highest reimbursement for the hospital from the private insurance companies. And so private insurance companies are the final decision makers when it comes to our healthcare options. And it becomes this vicious cycle. Some hospitals pick the strongest patient to take on, therefore they artificially inflate their survival rate statistics, which equals the insurance rewarding the hospital by reimbursing more. And so it incentivizes the hospitals to continue with that practice. And so I guess I was told that I was too sick to be transplanted, and one of the other program that I was referred to basically wrote me off. When I saw one of the pulmonologists there, their transplant pulmonologist, my son was 6 months old, and she basically told me that I was dying. And here we are 9+ years later, and there's no end in sight. And so I am a transplant success story that their survival rates wouldn't have predicted based on my LAS, my lung allocation score. And so I do think, from my perspective, that it needs to be a congressional priority. But as long as private insurance dictates how and where we as patients get treated, there will always be incentive for the hospitals to create outcomes that yield the highest return. And so we need to stop incentivizing the practice of cherry picking and implement broad reimbursement across the board, no matter what patient outcome statistics, and allow patients to be the final decision maker in their care. Now, I don't purport to have all the answers. I just know, as someone who has gone through the process, that the very first step in transplant, which is finding an institution.
Could I ask you to wind it up here?
Yes. So I just know that the very first step in transplant, which is finding an institution that will accept you into their program, is extremely arduous, and it's an added stressor that patients in that position shouldn't endure. So that's just my perspective coming from a patient. And thank you to the National Academy of Science, Engineering, Medicine for allowing me this time. Thank you.
Thank you for your comments. Janet Weiner or Weiner?
That is me. Thank you so much. My name's Janet Weiner, and I am the parent of 2 young adults with cystic fibrosis, and I am a member of the board of the Metro DC chapter of the Cystic Fibrosis Foundation. And I'm here today because my daughter is a person with cystic fibrosis who has been awaiting a liver transplant for more than 3 years. So as you've learned, CF is a rare disease, approximately 30,000 patients in the United States. People who know anything about CF often think of it as a lung disease, but the disease affects a wide range of body systems. CF liver disease affects only about 5% of the CF population, and CF liver disease progressing to the point of requiring transplant is even only a sliver of CF liver disease patients. To make matters worse, patients with CF liver disease represent only the smallest percent of the population of patients seen by most hepatologists. So these patients are zebras in a vast herd of horses. In addition to its rarity and the expertise of most hepatologists, CF liver disease is not well understood or even studied until only very recently. There are no effective treatments, and compared to other liver patients, the CF liver disease process is very different, and even predictions about which CF patients to watch, monitor are difficult to make. These patients present with vastly different symptoms than the typical liver patient. In my daughter's case, her liver failure came seemingly out of nowhere at the age of 20 after a persistent bout of CF-related constipation. Before her illness, she weighed about 150 pounds. She spent 6 months battling a mystery illness, unable to keep food down, constantly vomiting any nutrition. And despite showing clear signs of liver failure, such as varices, bloating, fatigue, doctors at 3 of the most prestigious hospitals in the United States failed to recognize her CF liver disease and the severity of it. As a result, she was in critical condition before she was properly diagnosed. And she was only diagnosed because of a late night visit to a different hospital, the ER at Georgetown Hospital, where they recognized the severity of her illness and took appropriate action. This is because to most of her doctors, she didn't look sick enough to be in liver failure. She never looked jaundiced. As a patient with a severe, serious chronic illness and a young, attractive woman still in college, I suppose she didn't complain loudly enough to be heard. To exacerbate matters, at her sickest, her model end-stage liver disease, or Meld score, was only a 25 out of 40, not sick enough to be considered eligible for a transplant in our area. Yet her transplant team had to surgically alleviate her ascites by doing an emergency paracentesis, removing nearly 18 pounds of fluid from her abdomen. After the procedure and her 6 months of not eating anything, she was down to 110 pounds. I'm here today to respectfully request that a critical structural issue be addressed. The Meld score calculations must be re-examined with a specific focus on the unique circumstances facing CF patients. Specifically, please consider allowing exception points to be added to the Meld score for all CF patients, not just those with severe lung disease as demonstrated by pulmonary function below 40%. Without these exception points, CF patients tend to earn a lower Meld score, even when seriously sick, than other older liver transplant list patients, simply because of their smaller stature, younger age, and in the case of my daughter and many of her cohorts, careful attention paid to their health over a lifetime of managing a serious chronic lung disease. Under the current Meld, CF patients with severe disease, liver disease, are routinely being denied liver transplant until, ironically, the liver failure triggers a precipitous decline in lung function. My daughter's lung function declined 30% due to her liver failure, but it was still not enough to merit exception points in her Meld score. Ironically, waiting until your lung function falls below 40% then requires both liver and lung transplant in these patients, worsening their long-term health outcomes and decreasing their likelihood of finding a donor organ even more. In conclusion, I beg you, please re-examine the Meld score for CF patients and grant exception points for all CF patients. CF patients are excellent liver transplant candidates because of their youth, and I would argue are uniquely qualified to manage the complex medical regimen associated with transplant. This is because on average, cystic fibrosis patients already take about 11,000 pills a year, inhale 3 to 4 medications daily, and commit to a lifetime of hours of chest physiotherapy daily. My own daughter, now 24, balances some 20 prescription medications, medical visits to 6 different specialists, multiple hospitalizations a year, as well as a full-time professional job and graduate school. Please give my daughter and others with cystic fibrosis a fair shot at a life-saving liver transplant by granting exception points to the Meld for all cystic fibrosis patients. Thank you.
Thank you, Janet. Last in the scheduled speakers for this session is Charlotte Woodward.
Hello, everyone. My name is Charlotte Woodward. I have a wonderful job at the National Down Syndrome Society as the Community Outreach Associate. Some of the things I do are talking with legislators about issues surrounding the Down syndrome community, make TikTok videos, do virtual public speaking, etc. When I was born, not only was I diagnosed with Down syndrome, I was also diagnosed with a congenital heart disorder. I had 3 open heart surgeries when I was a baby and had a 4th open heart surgery when I was 10 years old. All went well, and we hoped that that would be the last and final surgery. However, as time went by, I started to exhibit telltale signs that my heart needed help. My doctors determined that there was nothing else they could do surgically. My only option was a new heart. After being on the transplant waiting list for only 11 days, on January 30th, 2012, I ended up having a life-saving heart transplant. Although it is common for people with Down syndrome and other disabilities have co-occurring conditions like I do, it is rare for them to be offered the opportunity to receive organ transplants. This is because of discrimination based on their disability. Doctors and physicians may believe sometimes that a person's quality of life is less than someone without a disability, so they will not perform a transplant. Doctors, physicians, and providers may also have a misconception that people with disabilities are unable to manage post-operative treatment and will not benefit from a transplant. This is wrong. I am living proof that people with disabilities break these stereotypes. As my colleague, Ashley Helsing, mentioned earlier, we are working hard at the National Down Syndrome Society to ensure people with Down syndrome and other disabilities do not face discrimination for organ transplants. There is federal legislation called the Charlotte Woodward Organ Transplant Discrimination Prevention Act, the HR 1235, and I urge you to help me pass this very important bill. This bill will make it clear to hospital transplant teams not to discriminate against people with Down syndrome based on their diagnoses. People with disabilities have been discriminated against just because of their disabilities. This includes being denied organ transplants. It is an important bill for the Down syndrome and wider disability community. We need a fairer system so people with disabilities have equal access to organ transplants. Help us, please. Thank you.
Thank you, Charlotte. Let me turn to the committee and ask if there are any quick clarifying questions of any of the 11 speakers that we've just heard from. And I'm going to ask Rebecca and staff to help me with any hands since I don't have a full view of everybody.
I don't see any hands.
Okay, well, I invite all of our speakers to stay with us if they want for the rest of the session, and there will be opportunity at the end if we have time again for clarifying questions. At this point, we'd like to move the agenda from focusing on structural barriers to what might be done to maximize both public and professional trust in the system, and how or what steps might be made to make the system more transparent and accountable. And with that, we have 9 speakers scheduled. I believe they are all here. And with that, we will start off with David Goldberg.
Am I on?
You are.
Okay. Thank you very much for giving me the chance to speak today. I'm a transplant hepatologist at the University of Miami. I'm an NIH-funded investigator who's been working on research in organ donation and OPO metrics since 2015. The reason why I want to speak today is that there's been a misunderstanding and I think misinformation that's been disseminated in some circles about the new CMS OPO performance metric. And it's critical for public and professional trust that the committee recognizes the rigorous manner in which it was developed and will be implemented. I sent out slides for committee members to follow along with the 12-page public comment that I have submitted. So it's important to understand that the purpose of an OPO performance metric is not just to compare OPO performance for recertification, but to help OPOs improve and to improve the system of organ donation. High-performing OPOs can serve as model OPOs. Intermediate performers can be identified and may benefit from quality improvement initiatives. And low performers, unfortunately, may risk decertification. In a paper we'd published in sort of 2 peer-reviewed papers, we laid out the potential denominators that could have been used for an OPO performance metrics, which helps CMS in developing and determining what the ultimate data source was. This, again, is based on peer-reviewed data, and the metric that was chosen and the denominator reflects the lowest common denominator of standardized, objective, verifiable, and available data to assess OPO performance. Importantly, there have been several other metrics that have been considered and have been used throughout time. So the quote unquote international standard that has been used has been donors per million population. Now, there was a paper last year in JAMA which talked about comparing OPOs across different nations using donors per 10,000 deaths. Now, the calc denominator, which I'll get into, is much more downstream of that. It's important to note that some have put out that there should be use of inpatient ventilated deaths. And even after CMS approved the final rule, there was talk that there should be a metric that uses inpatient ventilated deaths. This has been sort of perpetuated, although there's things that are actually inaccurate about this. So this, and is based on peer-reviewed data, this metric, this inpatient ventilated death denominator, is actually not currently collected, would be an unfunded mandate for about the 6,000 US hospitals. There's no standardized definition of ventilated deaths. There's no automated system to collect such data, and there's multiple different electronic medical records across every hospital in the US. And this would require manual review for confirmation, both for confirming for data collection and for auditing, which obviously would be very difficult. The approved CMS metric uses something called the calc metric that was developed by myself and colleagues in collaboration and building on work that had been published before. Calc being cause, age, location consistent with donation, which looks at specific causes of death in inpatients under 75 years or younger, which captures about 98 to 99% of all deaths of people that ultimately become donors. These data use the CDC's National Center for Health Statistics. The NCHS data that would be used for this metric although based on death certificates, is not a simple cut and paste. Now, I put in my public comment, you can go to the CDC's website to look at the technical data as to how underlying cause of death data are ascertained. But despite what's been said, it's not simply death certificate data. This has been an established data source for researchers, scientists, and OPO leaders for multiple studies looking at organ donation and variability in donation rates, including by NASEM committee member Dr. Segev and many attendees on this call today. Now, there have been concerns about death certificates that have been unfounded, and there was even a letter to the editor at JAMA Surgery about this from a transplant surgeon at UCLA who had failed to mention that he was a board member of an OPO. In this, the person wrote that death certificates are error-ridden, they're variable, which is actually inaccurate. There are some issues with death certificates, but not related to the chain of events. And despite what was cited in this paper, what they called an error is that someone was coded as death from pulmonary hypertension instead of pulmonary hypertension due to systemic sclerosis. Death certificate have been shown to be 100% accurate for deaths from strokes. What we've shown in published peer-reviewed data is that more data, even if available, is not better and does not change among OPO comparisons. It just changes the absolute value of the donation rate. This is actually something that Dr. Segev, a committee member, had shown in a paper in JAMA Surgery, that although the donor potential data may be overestimated, the NCHS data is an accurate measure to compare two groups. In his paper, it was race and ethnicity. For the metric is OPOs. So again, a committee member agrees with what we found about this being a useful resource to compare donation rates. And again,
Dr. Goldberg, could I ask you to wind things up here?
And again, I would just point out that the CDC NCHS data has been the source of public health epidemiological death data in the US for 30 to 40 years, and that's why it's an ideal source for this metric. Thank you.
All right, thank you for your comments. Next, Martin Hatley. Marty?
Coming up mute. Good morning. Good morning to the members of the committee and my fellow colleagues here today. My name is Marty Hatley. I'm a patient safety advocate who have been working in this field for about 25 years. And I appreciate the opportunity to offer some information and some suggestions about improving patient safety in the organ transplant enterprise today. I want to raise especially today the safety improvement opportunity that comes along with engaging patients and their family caregivers, with family broadly defined as collaborators. Patient and family engagement is rooted in efforts to achieve patient-centered care, which itself is rooted in human rights. Basically, we as human beings are the owners of our bodies, and as such, we have a right to information others have about our bodies, including our providers, and we have the right to make decisions about our bodies. Achieving patient-centered care and patient safety are linked as two of the 6 synergistic aims set forth in Crossing the Quality Chasm, which is the National Academy of Medicine's 2001 seminal blueprint for transformation of healthcare in the 21st century. And to Ashley, Robert, Kelly, Jamie, Fanny, Janet, Charlotte, everyone in that first panel, equity is another one of these 6 aims, along with timeliness and effectiveness. And together, synergistically, they are truly transformational. The safety issues I'm concerned about in the organ transplant world include variation in waiting times from transplant center to transplant center, and the ways in which organs are declined, sometimes multiple organs, without the patient to whom the organ is offered being informed or consulted. And top of mind this week, I have to mention the news story about the transplant made with the wrong patient. Dr. Kaiser, Dennis, I know you are experienced in patient safety, and this is perhaps one of the classic patient safety issues, wrong patient surgery. There's a widely recognized framework for engaging patients and family caregivers. It's known as the Carmen framework after its lead author. It was published in Health Affairs in 2013, together with an editorial by then editor Susan Genser, characterizing patient and family engagement as the blockbuster drug of the 21st century because of the growing evidence of its impact on outcomes. The Carmen framework calls for engagement at 3 levels. Level 1 is the point of care, where providers actively partner with the individual to get the best outcomes for that person. Level 2 is intervention development, where providers engage patients for their lived experience expertise in designing programs, protocols, and continuous improvement work. And level 3 is policymaking and governance, where priorities are set and strategies are developed. At each of these levels, the signature activities are information sharing, collaboration, and shared decision-making, which are the core principles of patient-centered care. I've been involved in several research and implementation efforts focused on growing the evidence for patient and family engagement at all three of these levels. At the point of care, there are now very solid results. They show that the more engaged and activated a patient is in his or her own care, the better the outcomes. This is true across a broad swath of conditions ranging from managing asthma to heart or kidney disease to preventing HIV. It's quite troubling to me personally that in 2021, information about organ offer declines are not routinely shared with those to whom they are offered. I don't think this is in any way consistent with what patients increasingly expect now, 20 years into this century. As for levels 2 and 3, in the last decade especially, evidence is accumulating that bringing the patient perspective and their lived experience into co-design of programs, quality improvement initiatives, and strategic planning also improve results. The innovators and early adopters among hospitals, systems, and physician practices are operationalizing this by establishing patient and family advisory councils, where users of care are oriented and then appointing them to governing boards or key committees. Analyses supported by the Patient-Centered Outcomes Research Institute, CMS, and others show results such as reduction of infection rates, falls with injuries, pressure ulcers, and 30-day all-cause readmissions, among others. Patient and family engagement at all levels, but especially operations and governance, depends on leadership. And there are two leadership opportunities I'd ask the committee to consider today. First is a sector-wide structural commitment to track patient and family engagement across the sector and compare results. Can we measure how many transplant centers have patient and family advisory councils? How many share comparative performance data with them? How many engage patients in co-designing protocols or improvement interventions? How many have transplant patients sitting on their governing boards? The second is an opportunity for the innovators in the field, the leaders of particular transplant programs, to innovate by including patients and family caregivers in these kinds of collaboration and co-design efforts, perhaps starting with the variation in waiting times and decline rates, then looking at the patterns in the data that suggest solutions, such as biases, explicit or implicit, or the number of declines over weekends. Coupled with these recommendations that I offer today is a further offer from me to share patient and family engagement data and tools that might be helpful to the committee going forward. And I'll do that in written comments. Thank you for the opportunity to share these thoughts and suggestions today.
Thank you, Marty. Next, Emily Largent, and I'm going to ask Rebecca to take the helm for about 10 minutes here or so, and then I'll be back. Emily?
Thank you. So imagine for a moment that you're standing at the foot of a patient's bed in an ICU. The patient is a young woman with Down syndrome. Like roughly half of all infants with Down syndrome, she was born with a congenital heart defect. She's had several surgeries to repair her heart, but it now seems that she would benefit from a transplant. She is part of a large, close-knit family that circles her bed. They look at you and ask, what now? How will the transplant process be affected by her disability? As a cardiothoracic ICU nurse who routinely worked with pre- and post-transplant patients, I stood at the foot of that very bed and I faced those questions. And those questions have continued to trouble me long after I stepped away from the bedside to work as a medical ethicist. Therefore, I appreciate the opportunity to be here today and discuss discrimination on the basis of disability in organ transplantation and to identify steps that can be taken to promote trust and build a more accountable system. Much as making public spaces accessible helps people with disabilities as well as others, for example, curb cuts help people in wheelchairs, but also people pushing strollers, making transplants more accessible will help everyone. Everyone in need of a transplant is disabled by virtue of their organ failure. Therefore, I will use disability here to refer to situations in which an individual has an additional disability. Discrimination on the basis of disability refers to situations in which the mere fact of disability is used to justify denial of or lower priority for an organ transplant, or to situations in which a facially neutral screening criteria systematically disfavors people with disabilities when applied. It also encompasses situations in which disability impermissibly influences decisions about who becomes an organ donor. Such discrimination is not a new topic, but one that continues to urgently demand our attention. Despite protections afforded by the Americans with Disabilities Act and state laws prohibiting discrimination in transplantation, there remains an alarming, and as described earlier, empirically documented gap between what the law requires and what happens in practice. Part of this is attributable to a lack of enforcement, as well as to a lack of clarity on what the law requires. Additionally, a core tension in the ADA is that covered entities cannot deny a transplant solely on the basis of a disability. Nevertheless, covered entities are allowed to consider disability when making recommendations related to organ transplantation. for example, when considering the effect on likely outcomes. Consideration of disabilities makes sense insofar as we seek to maximize the benefits of transplantation, but it also allows bias against people with disabilities, problematic judgments on the quality and value of their lives, and unvalidated assumptions about compliance and outcomes to intentionally or not creep into transplant decisions and result in inequities. More must be done to address this. What steps can be taken to promote trust, transparency, and accountability? As a first step, it is necessary to ensure adherence to existing anti-discrimination laws. This means first, looking upstream of transplant centers to ensure that people with disabilities are receiving appropriate referrals for transplant evaluation. Second, providing individualized assessments rather than treating disability as an absolute or relative contraindication of transplant. Third, articulating what it means to offer reasonable accommodations for transplant, as ambiguities remain about what supports might be provided. Fourth, implementing procedural protections such as appeals and automatic reviews for people who feel they have been wrongly denied a transplant. Fifth, providing resources for enforcement actions. Sixth, systematically collecting data on outcomes for people with disabilities to refute arguments routinely used to deny them transplants, arguments that lack an evidentiary basis. And finally, considering the removal of some or all local control from transplant centers to allow for consistent, transparent, ethically defensible decisions. Second, while I realize this committee is focused on deceased donor organ procurement, it is necessary to consider organ donation by people with disabilities as well. Expanding access without increasing supply risks making a hollow promise to people with disabilities, and facilitating donation by the disabled without increasing access risks treating people with disabilities as mere means. Therefore, I would suggest that rules about donation by individuals who lack decision-making capacity should be formalized and emphasize assent of the person with disabilities. More radically, we might consider revising the dead donor rule, which is a legal fiction, and consider allowing for vital organ donation prior to death to allow patients or families who have decided to withdraw care to make the important and meaningful choice to become organ donors, which may ease their suffering by allowing something good to emerge from tremendous loss. Knowing such protections and rules were in place would have fostered my trust and ameliorated the distress I felt as a young ICU nurse, as well as helped the families in my care. Thank you.
Thank you so much, Emily. Next, we have Raymond Lynch.
You guys hear me?
Yes.
Great. My name is Ray Lynch. I'm a transplant surgeon and director of public policy and community relations at Emory in Atlanta. I've been conducting research on equity and access to transplant since 2016, and I'm grateful for the opportunity to speak with you today. I'll preface my remarks by noting that I've received research support from Mid-America Transplant Foundation and have provided uncompensated consulting services to several OPOs, but I have no personal financial conflicts of interest. Today, I'd like to focus on 3 misconceptions regarding the urgent need for improvements to America's organ donation system. These are that change is not needed, that change is not possible, and that change is not safe. The idea that change is not needed is based off the assertion that America, quote, has one of the best donation rates in the world. This statement comes from a paper often referenced by advocates for the status quo, where numbers of donors were measured against numbers of death in the United States and other Western countries. Unfortunately, the assumptions made in the paper don't stand up to scrutiny because of differences in how individuals die in the US. Published evidence shows that the rate of homicide in the US is 9 times higher than that in major Western countries, while the number of drug overdose deaths in the US is 9 times higher than those in Europe. As we saw in a Washington Post article published yesterday, the opioid epidemic has had a terrible toll on American life and has been responsible, as we have published, for much of the gain in numbers of organs recovered. These differences in how people die affect suitability for donation, so the donors per death metric is an unreliably crude measure of efficiency. If you want to know how well the system works, another question we could be asking is, how often are we getting a yes from potential donor families? This question can't be answered with data reported by OPOs to the OPTN, which is a strikingly different situation from that in other countries, where counts of both approaches and authorizations are made available in near real time. Multiple OPOs have stated that they would be able to provide these data with very little time lag, and so this is an answerable question for us. There's hope for the US because 7 OPOs so far have joined with the Federation of American Scientists in a commitment to full process data sharing, and these OPOs serve approximately 1/6 of the American population. So we're closer to getting this question. The last consideration on whether or not we need change is how well the system provides for all Americans. When viewed with the new objective CMS metric, it's clear that the gap between high and low performing OPOs has not significantly closed in the last decade, and a system that cannot detect and correct variation in performance cannot be said to be successful. So in answer to this first question, change is needed. The second misconception about improving organ availability is that change is not possible, at least for OPOs. This is commonly offered as an appeal to enforce or otherwise incentivize higher utilization of marginal organs by transplant centers. What this so-called global approach to addressing the organ crisis misses is that utilization depends on recovery. No center has ever implanted organs from an unrecovered donor. The OPO must be the primary focus of improving organ availability because of its position as the choke point in donation. If a given waitlist candidate refuses an organ, the center may try to place it with another patient. If the center declines, there are other centers to which the organ may be allocated. But if the OPO does not pursue the donor, there is no organ. And because of the local monopoly nature of OPOs, if the OPO does not pursue the donor, there is no recourse either for the referring hospital or for the decedent and their family to become donors. The need for center engagement is a parallel aim to OPO changes, but paradoxically, it's only apparent to us because center metrics that the OPTN has developed are so well tuned to detect variation in comparison to those of OPOs. And change is possible. We've published on the results of a QI initiative undertaken by one OPO in response to seeing their true performance. They had a 44% gain in donor recovery over 12 months that included the COVID-19 pandemic. This was done by the OPO without any new policies directed at the donor hospitals or transplant centers in their area. We also published that during 2019, when regulatory reform was first gaining traction, OPO productivity increased by 12.5%. That was a gain 5 times higher than the median in the previous decade. And the improvement came from previously underserved populations. So for myth number 2, change is possible at the level of both individual OPOs and the national system. The last misconception I'd like to address is that change is not safe for our system. This has been repeated for far too long by parties who should know better, with the most common version being that, quote, the government wants to decertify half of all OPOs. In one instance, this claim was repeated twice in a 3-paragraph appeal by UNOS to the families of donors asking them to support OPOs against government regulation. The reality is that the metric doesn't require a single OPO to close. Because of the confidence intervals applied to each OPO's performance assessment, a given OPO must only be within a reasonable distance of the median. The situation is analogous to runners crossing the finish line in a pack. There may be rankings, but as far as CMS is concerned, being in the pack makes everyone a winner. But for the runner who lags so far back that their confidence interval doesn't reach the median, there is a penalty. Where this analogy breaks down is that in the race, we would pity the eliminated runner, but in organ donation, it's the population in that runner's DSA that deserves our sympathy. The cost of lost donors is real, and it's measured in recipient lives. If you take 2 adjacent OPOs, Arkansas and that's based in St. Louis, and look at their comparison over the decade 2009 to 2018, you can see this difference. If Arkansas had had St. Louis's rate of recovery, they would have had an additional 487 donors and an additional 664 kidneys available for transplant. That's enough to provide a kidney to every waitlist patient from Arkansas who was died or was delisted for being too sick, and still have 300 extra kidneys to be exported from Arkansas, all from a DSA that represents less than 1% of the American population. The converse is also true. If St. Louis had mimicked Arkansas's performance, there would have been 700 fewer donors and 1,100 fewer kidneys available. If a safe and
Can I ask you to wrap up?
Okay, last thing. If a safe and efficient system is our goal, every day we trade in misconceptions and unsupported claims in defense of a broken regulatory environment is a step in the wrong direction. I hope you will join us in working towards a better standard so we're not reflecting on another decade of lost opportunities and lost lives in years to come. Thank you.
Thank you so much, Dr. Lynch. Next, we have Ginny Mcbride. Ginny, are you there?
In 1999, HRSA codified existing OPTN systems into its final rule. At the time, this
No, I just wanted to see if we could watch the other.
Yes. You hear me?
We can hear you. Can I ask everyone else to mute?
Can you hear me?
We can hear
Hello?
you, Jenny, but your audio is a little spotty.
Can you hear me?
We can hear you, Jenny.
All right, well, I'll just go then. In 1999, HRSA codified existing OPTN systems into its final rule. At the time this made sense, UNOS, the federally chosen OPTN contractor, was denying HRSA access to information to which HRSA was entitled. How HRSA structured the final rule then was necessary, but it limited what the OPTN's future could be. Limits such as OPTN board and committee membership and how many organizations could run it. Donation and transplantation are complex processes needing the expertise of non-OPTN members. Experts in technology, logistics, social sciences, organizational behavior, and others can contribute in meaningful ways, but there's no avenue for their involvement. Today's OPTN has become an echo chamber from which we must escape to solve our challenges. NOTA and the final rule must be examined. Our industry is more complex than when NOTA was passed, and its oversight structures are conflicted and overmatched. CMS finds OPOs fail to transplant at least 7,000 organs every year, with variability across OPOs as much as 400%. AOPO now admits the system is transplanting 17,000 fewer organs than it could. Thankfully, urgently needed reforms are coming from outside the industry, yet fought by many within. This begs the question, one posed to UNOS by the Senate Finance Committee: how has UNOS, as the OPTN contractor, either missed these shortcomings or neglected to remediate them? HRSA, now an OPO executive direction to have done all three. I have a unique preventing innovation to serve more thwarted monopolistically. As the New York Times wrote, UNOS has held the contract exclusively for more than 30 years, during which time the nation's organ shortage has risen steadily. A lack of competition has thwarted innovation, allowed the organization to become mired in bureaucracy, and made it resistant to change. Other groups have expressed interest in bidding against UNOS, but the government agency responsible for the contract has done little to encourage those bids. While at HRSA in 2001 and again in 2005, we tried to expand bidding opportunities, but each time the RFP and ultimately the contract went to a single entity. A new approach enabling innovation is needed. The path forward involves two discrete related steps. In line with HRSA's 2019 request for information for the tech component, the OPTN contract should be subdivided to allow for increased competition and much needed innovation. I no longer believe the OPTN or UNOS have the necessary resources to maximize donation and transplant. Outside partners are needed. No single entity can operate today's OPTN. In line with HHS's January announcement and as supported by congressional leaders, the past president of the NAACP, 5 past chief technology officers of HHS, and Nobel laureate Al Roth, the Division of Transplant and the OPTN contract oversight should be moved from HRSA to the Office of the Assistant Secretary of Health. The outside world is trying to tell us something. It's time to bring synergy to all federal agencies overseeing donation and transplant. OPTN oversight is not just about meeting contract requirements. It's about helping more people. HRSA has neither the budget nor the political influence to optimize the OPTN, but HHS does. UNOS has neither the resources nor the track record to bring genuine innovation to the OPTN, but HHS and Congress do. Finally, OPOs perform a critical public service, and the public deserves transparency. Our legacy is a proud founding member of the Federation of American Scientists OPO Innovation Cohort. Its purpose is to establish transparent lines of communication with the public, including the government, to build trust and support, and there's no reason they can't. Industry narratives will no longer be shaped by conflicted stakeholders and ineffective oversight. All parts of the country deserve to be served by high-performing OPOs as a matter of urgency and to be accountable for their performance now, given the lives dependent on it. Thank you.
Thank you so much, Jenny. And we could hear you. Your audio was a little spotty, but we got it. Thank you. Next, we have Constance Mobley.
Hi, good afternoon, everyone. Thank you so much for, hello, can you hear me?
We can hear you.
Yes. Hi, thank you so much and good afternoon, and allowing me to speak for this presentation. I just have some comments that I've been discussing with some of my other minority colleagues that really focus on the need for diversification and diversity in the field of transplantation. From a global standpoint, we look at transplantation, and our goal is to try and transplant as many patients as possible and to remove any obstacles for performing this very life-saving and life-changing operation. We strive to find ways to remove these obstacles and say yes, as opposed to finding ways to say no to patients and transplant them. One of the areas of which there is room for improvement is transparency and our psychosocial support evaluation. As a minority physician and both a woman and as a Black woman in transplantation, I often find that the psychosocial support evaluation can be hindered by bias. This bias is not intentional, and I believe that improving the diversity of the team providing care and doing the evaluation for this patient can often overcome these obstacles. In many centers, there have been implementation of psychosocial programs to improve the amount of support that recipients get, as well as improving the rate of donation for minority populations. If we are able to spread these programs throughout different transplant centers, I believe that we would not only improve the rate of transplantation for recipients, but also possibly improve the rate of donation. To improve the rate of donation, I believe it is incumbent upon the transplant centers to go out into the community and improve outreach to these underserved communities, which are largely the populations who our donation of organs come from. And although they more often require transplantation, are less likely to be transplanted. So my comments go toward improving the standardization of our psychosocial policies across transplant centers so that there's more transparency, that there's more equitable distribution of organs and acceptance of transplant recipients for these life-saving operations. Implementation of more social support programs so that there's improved acceptance for patients for transplantation. And also improved documentation and data collection to increase equity for transplantation in these patient populations. I think that a large part of this can be alleviated by improving the diversity of the care teams taking care and making the decisions for accepting these patients. And that's an area for which we can strive to improve. So thank you for allowing me to make these comments, and hopefully we can all work toward improving the diversity in our patients.
Thank you so much, Dr. Mobley. Next, we have Blair Sadler.
Good morning. Can you hear me? Good afternoon, I guess.
Yes, we can hear you.
Thanks, Rebecca. I appreciate the opportunity to speak with you today on the vitally important issues of public and professional trust. 55 years ago, this summer, my physician twin brother and I began work as a medical legal team in the director's office of the National Institutes of Health. Our first assignment was stimulated by two leading newspaper articles published in Los Angeles and Minneapolis with the attention-grabbing headlines, "Bare Human Gland Sale" and "Coroner's AIDS Robs Corpses." Since NIH was funding research on procurement and use of pituitary glands, they were keenly interested and concerned about the legal and ethical issues involved. In short order, we became heavily involved as consultants to the Uniform Law Commission and in drafting the Model Uniform Anatomical Gift Act. When Christian Bernard performed the first human heart transplant in December of 1967, A host of questions were raised about how to make more organs and tissue available to save lives, but also how to protect the interests of individuals and families. We completed the model law in the summer of 1968, and it was approved by the Commission and the American Bar Association the very next month. But most importantly, it was adopted by all 50 states with little or no change in just 3 years. Why was the law adopted so rapidly and easily? It was based on the cardinal principles of voluntarism, autonomy, and trust. People believed that they might be able to save a life or advance research, and they trusted the transplant systems to be honest and trustworthy. Today, however, despite the considerable advances made in organ procurement and transplantation, I believe we are approaching a crisis in confidence in transplantation. We are reaching a inflection point about the future of the organ donation system. I say this for 3 reasons. One, the 400% difference between the best and worst performing OPOs is unacceptable and inexcusable. We would not tolerate this in any other area of medicine. As the president and CEO of Rady Children's Hospital in San Diego for 26 years, I can tell you that under similar circumstances, we would be placed on probation by the Joint Commission. And if major improvement had not been made, we would be shut down, and we should be. Second, the recent congressional hearings on OPO performance and the editorials in the Washington Post and New York Times have raised serious ethical questions about the way some OPOs are managed. Excessive executive compensation and perks concern me. Are floats and Rose Bowl parades, season tickets to professional sports, and retreats in Napa reasonable and legitimate expenses for nonprofits to incur and then bill Medicare? Who is minding the store? Where are the OPO boards? The optics are terrible. The ethics are terrible. 3, there also appears to be inadequate oversight of the substantial revenue-generating commerce engaged in by some OPOs that include the sale of tissue outside the US with no knowledge of the families. We do not need, nor can we afford, another Tuskegee in organ and tissue procurement. This is a time bomb waiting to go off. I asked the committee, are you okay with this? To me, the answer to all 3 points can only be a resounding no. If OPOs stopped extravagant spending on lobbyists to oppose any changes and protect the status quo and used the same money to improve their performance, they and all of us would be far better off. I will close with a personal story. In 1980, I had been CEO of Children's Hospital only a few weeks when 3 babies died in our NICU of unknown causes. We convened a press conference every night to share what we knew and did not know. Ultimately, we discovered that we had a bacteria in our air handling systems, the first case of Legionnaire's disease in a hospital in America. 6 months later, we actually, because of our complete honesty and transparency, received awards from various public relations organizations. As a nation, we cannot afford anything but full transparency by all parts of our organ donation system. I hope that your committee report includes clear and compelling recommendations to improve disclosure, accountability, and transparency. We cannot afford to wait. The stakes are simply too high. Our patients and families deserve it. Our nation deserves it. Thank you.
Thank you, Blair. We will next turn to Greg Siegel.
Thank you, Dr. Kaiser. So my name is Greg Siegel. My father received a heart transplant, as did one of my aunts. Another of my aunts died 18 months ago for lack of a transplant, and I have other family members who will need transplants too. Since I founded Organize, a nonprofit patient advocacy organization, more than 100,000 Americans have died waiting for organ transplants. That reality and a sober look at the data will animate everything that I say today. Organize served as the innovator in residence in the office of the Secretary of HHS, where we married the fierce urgency of patients with the methodical policymaking apparatus of the civil service. I personally have spent as much time in hospital waiting rooms as I have in government offices. Today's session is about maximizing public and professional trust, what steps can be taken to build a more transparent and accountable system. I think it's important to separate those themes and to examine them individually. So first, on trust. Known and provable system failures show that trust has not yet been earned. By CMS's data, holding OPOs to even basic performance standards will lead to more than 7,000 additional life-saving transplants every year. And AOPO's own projections paint an even starker picture. Its 50,000 organs PR campaign suggests a breathtaking level of failure in the current industry on the order of 17,000 organs annually. And yet, even with a death toll so staggering, OPOs have continually fought to stall or delay reform, even as, in the words of a tier 1 OPO CEO, who I'm quoting, this was in the Harvard Health Policy Law Policy blog, quote, every major patient group engaged on this issue has universally supported HHS's new OPO metrics. So to earn public trust, OPOs should be focused on maximizing organ recovery and placement. But too often in recent years, the focus instead has been on self-congratulation and on lobbying to evade any accountability from the government. Consider that virtually every formal statement from AOPO over the last few years has necessitated a fact check from patient advocates, public policy experts, researchers, and even its own OPO members, all of which I'll send to the committee in my written testimony. And as one top performing OPO CEO testified before Congress, quote, in the OPO industry, truths can be hard to come by, often by design. So what patients deserve is oversight and transparency. To this session's question, what steps can be taken to build a more transparent and accountable system? I'll ask you to consider the case study of the OPO based in Indiana. After oversight inquiries from Indiana Senator Todd Young, the OPO increased donations by 44% in 1 year. The OPO didn't somehow increase levels of public trust by 44% over that same period, but instead simply responded to 57% more cases. In other words, when faced with scrutiny about its performance, the OPO exerted more effort, which is exactly the behavior we should all expect from OPOs in the first place. And while Indiana may have been a pronounced example, it certainly was not anomalous. I'm going to quote Dr. Ray Lynch's research. Peer-reviewed research finds that in 2019, the first year of extremely heightened OPO scrutiny, donation rates relative to actual potential grew by 12.3%, representing a change of nearly 5 times the median growth over the preceding decade. As summarized in a report by the Bridgespan Group, this is a quote, since the executive order announcing the proposed new metrics and increased oversight, data show that OPO performance has already begun to improve, perhaps early evidence of the Hawthorne effect. That such gains were possible and yet unmade prior to the executive order underscores the importance for HHS to institutionalize such regulatory pressures for OPOs to improve performance. I also want to note that Bridgespan's research was into the 71 historical OPO mergers and concluded that, contrary to much fear-mongering regarding the enforcement of OPO accountability, never once has this process been disruptive in any way. Given the staggering failures of the current system, as a patient advocate, what I fear most is a perpetuation of the status quo, not a change of it. So I want to offer the committee a concrete and actionable suggestion. 7 OPOs, in partnership with the Federation of American Scientists and in interest of, quote, transparency, equity, and accountability, committed to publicly sharing all of their process, financial, and governance data, noting that, quote, this is data which can be easily and readily shared by all OPOs. This committee has an opportunity to recommend that CMS require the other 50 OPOs to follow suit. If patients cannot trust OPOs, we can at least achieve the same life-saving outcomes by auditing them. I'll end with another quote from the Harvard Law blog from the OPO CEO, quote, as a network of government monopoly contractors managing $3 billion taxpayer dollars annually, objective evaluation of our performance seems to be the very bare minimum patients and government should expect in return. Thank you.
Thank you, Greg. Our last speaker in this session is Marion Shuck.
Good afternoon, everyone. Thank you so much. Thank you to the committee for inviting me to speak today as I share your goal of, at long last, creating a more transparent and accountable system. As both the president for the Association of Multicultural Affairs and Transplantation and a donor family myself, I am uniquely qualified to speak on the opportunity for transparency for underserved and marginalized communities. For the past 30 years, many assumptions have been made about these communities. The most damaging assumption that families in these communities are hard to approach and unwilling to donate organs and tissues. This is simply not true. Unfortunately, these assumptions are the core of a negative cycle in which OPOs and government agencies assume that families in underserved communities are difficult, so they do not get asked. This unnecessary barrier negatively impacts everyone by mitigating minority communities' chances to participate in the organ and tissue donation process, by not allowing them to realize their benefits as donor families and recipients. Therefore, to build a more transparent and accountable system, a commitment to recognizing the value of ensuring all communities are given the same opportunity to donate through a system that values their participation is paramount and allows them to advocate for themselves as well. I want to share my own personal donor family experience as it paints a picture of all that can go wrong in the donation process, including and especially for families of color. Although I'm an executive at an OPO, my donation experience when my husband died 2 years ago was anything but positive. Without my professional connection to donation and knowledge of its benefits, the decision to donate would have been harder and possibly would have been a no in the face of the tragic circumstances I experienced. I nor any family should have to experience pre-traumas before we get to the donation conversation. I see our legislators in the new CMS metrics as holding OPOs and industry partners accountable, especially for these communities that have been blamed for their lack of participation. While I support the many steps and suggestions that can be taken, my 3 top priorities center around OPOs, transplant centers, and donor hospitals, bridging the gap from community to clinical by developing a positive culture for donation from communities to hospitals. A strong and collaborative partnership between hospitals serving minority and underserved communities and OPOs sets the stage for empathetic conversations with families regarding donation. Bridging this gap allows minority communities to see the opportunity to choose donation as a continuum of the healthcare cycle. These communities must be embraced and welcomed into the hospitals when they experience a tragic circumstance, and providers must recognize these families deserve comprehensive end-of-life care that includes the chance to donate presented every time it is appropriate and in a compassionate manner. OPOs must commit to developing and maintaining culturally competent staffing models. Please note that when I talk about culturally competent, I'm not just talking about race and ethnicity. I'm talking about urban versus rural, educational experiences, socioeconomics, and a host of other things that make us different from each other. But these problems are more than just anecdotes and personal stories. They are supported by a wealth of peer-reviewed research. For example, some OPOs are half as likely to even respond to a donor referral involving a Black versus a white family. And even when some OPOs do respond, they have been shown to provide us with deeply substandard and less compassionate service. To quote Ben Jealous, the past president of the NAACP, who wrote in support of HHS's OPO metrics, the obvious corollary to Black Lives Matter is that Black deaths matter too. These failures have tragic implications not only for donor families of color who are often denied this vital component of the bereavement process, but also for recipients of color. But it restricts all recipients' access to organ availability. That is why Congresswoman Ayanna Pressley so powerfully noted, we must confront the racial injustices in our organ transplantation system as a matter of life and death. And finally, unfortunately, Congresswoman Pressley is not alone. Bipartisan leaders in both the House and the Senate have begun recently advocating strongly for OPO reform as an urgent equity issue, including and especially in support of HHS's recent finalized OPO metrics, which encourage recognition of Black and Brown families as part of the circle of donation. If I have one final message to this committee, it is to consider that racial inequities exist across our entire society and very often are the root cause of healthcare disparities. While the HHS metrics are a good place to start, there's more we can do and more the committee can recommend, especially focusing on inclusiveness, continuum of care, and transparency to the communities we serve. OPO should welcome full reporting and transparency on all process data so the public and regulators can objectively assess how variably OPOs treat different ethnic communities. Thank you for allowing me to comment on this most important conversation.
Thank you, Marion. We have a little bit of time if there are any clarifying questions from the committee members. And again, Rebecca, I'd ask you to help me identify anybody who has any questions. Alex, did I see your hand up?
Yes, you did. I'd like to ask Mr. Sadler whether any of the reforms that he and Alfred Sadler urged back in 2018 have been achieved, and whether any of them that have not should be at the top of our list when they wrote about the 50-year experience in 2018 following the Uniform Anatomical Gift Act.
Thank you, Alex. I would say on balance, the answer is no. I'm particularly worried in terms of your second question about what's the top of the list besides the overall transparency and trust theme is the apparent tragic oversight of tissue procurement that I mentioned in my testimony and we mentioned in that article. That seems, you know, if we're building a security system for a house and we would be adding, it's like the back wall of the houses doesn't exist. And so that I think is a massive concern. I would also say this disparity that I talked about, that many others have commented about between OPO performance, that massive variability is really unconscionable. And the collaborative model doesn't seem to be at play that we learned from IHI collaboratives. Ken Kaiser, you're very familiar with this, as you are as well, Alex. So I think these very specific reforms are needed. I also, where sort of, as I asked rhetorically, where are the OPO boards? Where is the oversight? Where is the accountability? It seems remarkable that there isn't any pushback from within any of the OPOs. I may have missed a few, but I haven't seen them to make major changes. They seem to always be externally driven. And therefore, I think the committee's well positioned to exert the kind of influence that the IOM did with crossing the quality chasm 25 years ago, where it really laid out. And I know the reaction of the industry at the time was sort of a Kubler-Ross denial. We're the best in America. We've heard a lot of that. Oh, the numbers are wrong. We heard a lot of that. Well, that applies to others, but not to us. Before we finally even got to an acceptance level. I think we're probably close to an acceptance level by everybody, but some of the industry leaders themselves. And I'm hoping you all can accelerate that process.
Thank you.
Thank you. Other questions to clarify any of the comments that speakers have made here? I don't see any other hands. And absent that, I think we will go ahead. We're just about on time. Amazingly, perhaps a couple of minutes in front. We're going to take a break. We've orchestrated this so that speakers have some expectation of when they will be called upon. My inclination was to jump to the next session, but I think because people are planning to come at, not everyone's going to listen to the whole thing, and folks are going to come at kind of their window. So we have factored in a 20-minute break for whatever one wants to do in those 20 minutes. And so we will reconvene just a little bit after 1:20 on East Coast time. For those of you in other time zones, you can make the correction yourself. But so with that, we will stand in recess for about 20 minutes. Thank you again for everyone, and look forward to rejoining in a short time. Thank you. Okay. I think time has elapsed. So we are going to go back on the record here and resume this public listening session. This third session is focused on aligning incentives and what might be done to increase the efficiency and effectiveness of the organ transplant system. We have 7 speakers for this session. I would again remind everyone of the 5-minute limit to comments. After we've heard from all the speakers, we will ask the committee for any clarifying questions. But we, in the interest of time and the number of speakers, we shall have one more session after this. We won't be really engaging in any discussion. To lead us off for this session, Clive Callender, the microphone is yours.
I'm Dr. Clive Callender, the founder of National MOTEP, the National Minority Organ Tissue Transplant Education Program, and professor of surgery at the Howard University College of Medicine. I've been a transplant surgeon since 1973. Systemic institutionalized racism results in deep-rooted subconscious or conscious classification of ethnic groups into superior and inferior classes, and maybe the most important obstacle to overcome as we try to eliminate its devastating negative impact on those deemed inferior. The following recommendations may help increase the effectiveness of our organ transplant system, which impacts both dialysis and transplant patients. First, put in place dialysis and transplant advocates and navigators. There are many obstacles to getting a transplant and to getting on dialysis. Many of these can be helped by providing this support for dialysis and transplant patients. Next, provide literature for dialysis and transplant patients that is more culturally competent and linguistically appropriate and at the literacy level of these patients. Next, ensure that options for transplantation, when they are presented to dialysis patients, that they accurately reflect the nature of the mortality and quality of life difference between both options. The annual mortality rate for dialysis is 10 to 20 times that of transplantation. Is there evidence that these options are clearly explained and understood? Next, emphasize diversity and the use of more underrepresented minorities in the medical and scientific presentations given by them to elementary school levels and above. Include more dialysis and transplant patients' community and social factors in their management plans and in all aspects of their patient care. Is the number of social workers adequate for dialysis units to accomplish this? Next, educate all dialysis and transplant healthcare professionals about their implicit and explicit racial biases. Next, use culturally competent and linguistically appropriate mentors for all dialysis and transplant healthcare professionals, regardless of their ethnicities. Next, employ systems which make it comfortable and safe for dialysis and transplant patients to report racially inappropriate behavior without fear of reprisal. Next, there's the need for the development of a national strategic plan with goals and implementation dates, which allow for community participation in an effort to eliminate institutionalized racism in the organ transplant system. There's a need for the majority and the minority communities to work together with dialysis and transplant health professionals to aggressively eliminate systemic racism. Then there's the need for greater involvement of the minority communities and the education of the way to prevent the maladies identified by the adoption of healthier lifestyles. And finally, these are some of the measures we can take to help eliminate the negative impact of racist policies and practices which exist, and to help provide more accountability when racist behaviors occur within the organ transplant system. These measures, I believe, will help increase the efficiency and effectiveness of the organ transplant system as it impacts all of its participants. Thank you for the opportunity to present.
Thank you, Dr. Callender. Next speaker is Osama Gaber, and forgive me if I've botched your name. Are you on mute? Or?
He's on mute. He's on mute.
I'm so sorry. Good afternoon. I'm Dr. Osama Gaber. I'm the director of the Houston Methodist Transplant Center and the president of the American Society of Transplant Surgeons. The American Society of Transplant Surgeons is a society of surgery and other professionals, about 1,900 of us that are working in transplantation. The ASTS welcomes NASM's interest in rethinking transplantation. I want to emphasize that while today we are commenting just on the alignment of incentives and regulatory environment, we have submitted statements for the record on other areas of interest to the committee. Particularly, I want the committee to pay special attention to the ASTS initiative in the area of advancing equity. It's titled ASTS Boldly Against Racism, and you'll find it in your material. The ASTS aspires to reimagine the transplant ecosystem. Our vision is a transplant ecosystem that is patient-centric, designed to improve organ failure, patient survival by doing four things: improving organ availability, maximizing utilization, achieving high-quality outcomes, and fostering innovation. We call on you to think of standing the system on its head and reconceptualize the care of patients with organ failure from what you heard from the patients that testified earlier, to introduce transplantation actually at the correct time. And if you look, for example, at kidney patients, we can reimagine late-stage chronic kidney disease and change the system from a dialysis-centric system that was built in the 1960s to one that prioritizes patient benefit through transplantation. Achieving this vision requires aligning financial incentives and streamlining and aligning regulatory and third-party incentives for transplantation. We think there are several meaningful short-term steps that could be taken to better align the incentives with the objective of increasing clinically appropriate transplantation. First is to change the transplant center performance assessment from those based on competitive letter grading or star rating post-transplant outcomes, which run counterproductive to the achieving the best patient benefits. Even the worst performing quartile of transplant centers have an average success rate at 1 year of 93%, which is far exceeds that of staying on dialysis. We should remove those letter gradings and change transplant certification into certified and non-certified, just like we do with laboratories and bariatric programs and so forth. On the other hand, we should create a national system of quality improvement that all transplant centers are involved in to help the continuous improvement of transplant outcomes, which is very important in maintaining organ availability. We should risk adjust not to other centers, but to the comparable treatments that the patient has opportunity for. For example, kidney failures, we should risk adjust to staying on dialysis. That is the benefit measure that we believe the patients understand. We should measure and report the quality and duration of organ function, return to work, quality of life, and other things that are important for the patients. And maybe as a revolutionary thought, we should actually ask the patients with organ failure and kidney disease to design what they need to be measured to achieve their benefit. We also believe that emphasizing living donation, overhauling the pre-dialysis care, particularly patients and family education to eliminate disincentives to living donations, whether it's kidney living donation or liver living donation, is very important. And the system should focus on that intently because it's one of the major sources of increasing transplant access. We should revise the organ allocation system to facilitate utilization of organs at risk of discard. Discard is not just a transplant system function. Not every organ can go into every patient. The system does not allow the transplant surgeons and professionals to put the correct organ in the correct patient. You have to go through hundreds and sometimes thousands of patients to get the correct function, which makes it impossible or very hard to use these organs. Our longer-term objective is to convene a national transplant system redesign effort that creates a patient-centered system that maximizes transplant benefit by adjusting regulation, oversight, reimbursement, and reporting. We should remove the duplicate oversight transplantation by HHS, CMS, HRSA, OPTN, SRTR. We should pilot new value-based systems, and the ASTS has submitted some proposals to Medicare to look at piloting a system that aligns the incentive of multiple stakeholders in the transplant effort. Improving access to care and equity is important. We should eliminate racial and other biases in the system. We should recognize geographic heterogeneity in death, dialysis, transplant listing, transplant performance, and try to make up for these. We should increase organ availability for use by placing the right organ in the right patient. We should link transplant center and OPO metrics so that the whole system is rowing in the same direction and to optimize the benefit from organ availability. And we should structure national quality programs to continuously improve post-transplantation outcomes. This vision is bold, and it will take the commitment of disparate providers, regulators, professional societies, patients, patient advocates, and other organizations. But we think it's doable, and we think we should actually start embarking on this trip right now. We caution against quick and simple solutions that tinker with one element of the system only to discover unanticipated consequences in others. Adding more things to measure can only increase the risk aversion behavior of transplant centers, particularly if these measures will result in punitive actions from regulators. I want to thank NICEM for its involvement in this field, and I think that together we can actually achieve significant improvement for the transplant ecosystem. Thank you.
Thank you, Dr. Gaver. Our next speaker is Michelle Goodwin.
Thank you very much for having me today. Good morning, committee members and guests. My name is Michelle Goodwin. I'm a chancellor's professor at the University of California, Irvine, and the founding director of the Center for Biotechnology and Global Health Policy. I write and teach in the areas of constitutional law and tort law and bioethics, biotechnology, and health law. My scholarship has been published in numerous law reviews, including the Harvard Law Review and the Yale Law Journal. And my books most relevant to our discussion today include Black Markets, The Supply and Demand of Body Parts, and Altruism's Limits. Over the past 20 years, I have written about health inequities and disparities, including within this particular domain. The death toll resulting from organ failure is high. You all know this. It is not declining, yet more people are added to the organ wait list each day. Let us examine what this means in real terms. Each day, 17 or 18 persons on the UNOS wait list die before ever receiving the anticipated organs. They're replaced by dozens of other people who will enter that list by the end of the day. This number rises each year. The dramatics of who enters and exits would be far less onerous if it were an equilibrium between who enters and exits. If we consider the demand only for kidneys, notice the number of candidates added to the wait list each year, we would see only increases. One person becomes a waitlist candidate every 9 minutes. That was 13 candidates per minute 15 years ago. As of an hour ago, over 107,000 people in the US were on wait lists. 90,000 of those people are waiting for a kidney. Now, these figures only scratch the surface of the gravity of our organ demand. The committee is aware of these statistics, but I speak not only to the committee, but the broader public engaging in this discourse. The crisis in US organ transplantation is only partially addressed by the actual organ shortage. The balance of the equation requires us to honestly consider the limitations of our procurement system and strategy that have been mired by fraud, racism, and a lack of continuous high-level engagement of people of color, particularly African Americans, in the bodies that govern and dictate the future of organ transplantation policy. So here, if nothing more is recorded, we should keep in mind three matters. First, African Americans disproportionately suffer the greatest consequences of our current organ transplantation system. African Americans wait longer than any other group, die at disproportionately high rates, whether they make it onto a list or not. That is a discussion that we should have in terms of inequities at the entering stages, and are more likely to be kicked off or transitioned off the list before receiving the needed organ. Three, esteemed commissions, committees, governing bodies have too long sidestepped, overlooked, or ignored prioritizing African American scholars, researchers, civil society members in the composition of the bodies to study these matters. And here I'm not talking about adding one or two people, but given the gravity of these circumstances that have been well documented and articulated over decades, it is a shame in these days that there has to be tremendous advocacy in order to get African Americans onto the bodies that govern or discuss or talk about these issues. And it's not for a matter that there is disinterest on the part of African American doctors, researchers, scholars, civil society members. It's that they are not asked. They're not asked in the volume of participation in which they should be. We only have to look around at the records of these committees and commissions to see the representation of Black Americans and other people of color. What I am describing to you is that despite the grave consequences that all Americans experience within the organ transplantation systems, the gaps of thoughtful, consistent engagement of Black Americans is noticeable. As for my remarks today, I want to concentrate on a couple of issues that include our current system of procurement and fraud, rationales once used to justify the prohibitions on incentives for organ donation may be less persuasive in an era where demand for transplantable organs is exceptionally higher than 40 years ago when the Uniform Anatomical Gift Act, UAGA, was originally drafted, and in 1984 when the National Organ Transplantation Act became enacted. At the time, U.S. bans on organ sales, at that time, U.S. banned organ sales, but transplantation was more of an implausible, consistent reality. Transplants were episodic as relatively few transplantations occurred in the 1970s and 80s. In 1984, a transplantation system based purely on altruism was compatible with our medical capacity and social trust of biotechnology. Moreover, the medical technology to sustain transplants, cyclosporine and other drugs, were yet to be developed. Thus, the collective concerns of urgency, biotechnology, and social confidence in the transplantation system are far different today than they were 40 or 50 years ago, or even 20 years ago. Altruism may be the most noble form of giving, especially in the context of organ donation, but how many people need to die before we rethink our procurement strategies? As the death toll mounts, demand for organs continually outpaces the supply, resulting in rationing that at times could be considered arbitrary and capricious. The most noticeable flaw in the altruistic procurement process is system incompetence. By this, I'm suggesting that if altruistic procurement is designed to meet the overwhelming need for organs, it is a numerical failure. In this way, it closely resembles a sophisticated lottery system rather than a reliable supply system. Altruism, many commentators suggest, is a losing battle wait list delays and the rising death tolls of those waiting for organs gives indication that the system has stretched beyond its capacity. Such system failures have real painful meanings for the critically ill. These realities exist not in the abstract, but the interface in concrete, controversial ways. This problem is not a shortage of human tissue, bone marrow, or organs. Rather, legal options for obtaining human tissues, organs, etc., have become limited. But through this limitation, what has emerged and is deeply disconcerting are the kinds of black markets, the kind of markets with which we live with. The demand that we see now is not only within the context of organs, but it has also included human tissue, and in ways that now altruism veils the existence of thriving Black and gray markets. In direct response to indefinite delays on national transplant wait lists, a growing number are turning to international underground markets and brokers for organs. Americans receive hearts, lungs, kidneys, and other body parts through underground or black market processes. Chinese inmates on death row and the economically disadvantaged in India and Brazil and other places where I have studied on the ground are often compromised co-participants in the private negotiation process, which occurs outside of the legal process or the shadows of law. Now, as I begin to wrap up, I want to draw attention to two major problems that exist within our organ allocation process, and they include shortage and bias. In my written remarks, I will supply them to the committee that further explores what this looks like in concrete terms, such as controversies at the University of Illinois, at the University of California at Los Angeles, with misappropriation of human tissue and organs. These are real matters that we should pay attention to. I appreciate the committee for inviting me today to provide commentary. And I'll just close with saying that it is incredibly important that we do a better job of being inclusive in our analysis and including in robust and substantial ways people of color in the deliberation and discussion about these issues. Thank you.
Thank you for your comments. Next is Paul Myung.
Hi, good afternoon, everyone. My name is Paul Myung. I am the transplant administrator at Massachusetts General Hospital in Boston. And I would like to thank the committee for this opportunity to share my perspective as a transplant administrator. But also, I trust my fellow panelists will share insight on how essential it is to align incentives within the current organ transplant system and between OPOs, transplant centers, as well as our patients. However, I would like to use my limited time today to share how important it is and the need to align incentives within one's organization around the mission of increasing donation and transplantation, where a hospital or a health system has many different competing priorities that might challenge these efforts. I wanted to provide this committee with two concrete examples of deliberate efforts to align incentives within MGH and how they have led to increased effectiveness of the system as well as utilization of organs. Back in 2017, we launched a hepatitis C clinical protocol that was looking at increasing the utilization of organs from hep C positive donors transplanting into hep C negative recipients. We've faced many different challenges due to the fact that at that time, insurance coverage and the nascent drugs that were moving forward around curing hepatitis C were really challenging our system around getting the coverage necessary so that patients would not be at risk financially. Therefore, we need to advocate to the senior leadership as well as to our president for backstop funds in case there were situations where a payer would not pay for the hep C treatment. And so we would need to be able to advocate on behalf of the patient so that they would not incur that expense. Since moving forward with that in 2017, our region has actually more than doubled use of the hep C organs, and we have also increased significantly our use of hep C organs at Mass General. And also, given the fact that our Region 1, which is in New England, has a higher incidence of hep C due to the opioid crisis, this has continued to increase utilization of these organs, and we have since transitioned from clinical protocols over to standard of care. This would not have happened if we did not have an alignment with our hospital for these additional resources. The second concrete example I wanted to share was the investment into the TransMedics organ care system for our hearts, lungs, and livers, which essentially is a device that is an organ perfusion preservation device that allows us to use more marginal organs from further distances in order to optimize them for transplantation and better outcomes. This required a very significant initial capital investment in order to bring the device in-house. Due to the contracting language, we needed to use our capital in order to purchase the devices outright upfront before using them. And so when we were looking into building a business case for this, as you can imagine, the return on investment was very small, or it was not positive in the long term, and using traditional hospital finance methodology. However, after multiple months in working with our finance colleagues in order to create better alignment, in order to articulate the net benefit in using this, this device, we had to switch our perspective and actually be able to articulate the opportunity cost in not performing or using these devices for bringing additional organs into our region. So in order to do that, we had to really switch our impression of how we look at the organs that are not being transplanted. How do we quantify that financially? And also, how do we make sure that that aligns with our hospital's financial system? And I'd like to announce that due to this, we moved forward with this, and we proud to announce that we performed the country's second DCD heart transplant because we had put this forward and because we were able to get the TransMedics device approved. And so without the hospital's resources to support our transplant efforts and the additional alignment with the hospital priorities, we would not have been able to do so. And I just wanted to leave this committee with how essential our shared responsibility is as a community to actively collaborate and continue our essential efforts on aligning incentives against other misalignments to our shared mission. Most recently announced was the CMS proposed rule, which has a provision that would negatively impact our organ acquisition cost reimbursement to both the OPO as well as the transplant center. And we've mobilized as a Region 1 collaboratively to address this over to CMS. And we are continuing that effort as we speak. And we really appreciate the collaboration with our New England Donor Services colleagues, as well as our other transplant centers to continue on moving forward with aligning incentives.
Thank you, Paul. Appreciate those comments. Next is Howard Nathan.
Thanks, Dr. Kaiser. My name is Howard Nathan. I'm president and CEO of Gift of Life Donor Program based in Philadelphia, and I've been in the organ donation field for 43 years. I'm very proud of our Gift of Life team and being the largest provider of organ donors and organ transplants in the nation for the past 13 years. I believe the U.S. system is one of the best, but there's certainly room for improvement. And I have some practical suggestions for how we can align the players in this system, the OPOs, the transplant centers, donor hospitals, donor families, and recipients. It should be noted that over the last 10 years, donation has increased 55% in the US and organs transplanted by 48%. And just this year, as was noted by Brian Shepard, there's an increase of about 10 to 11% in organ donors and about 7% in transplants. So why is that particular statistic not aligned? Well, what's been happening is the increased number of donors is coming from DCD donors and older donors, which yields fewer organs transplanted. So in order to increase transplants, transplant centers must find ways to increase the utilizations of the donor organs being made available by OPOs. For example, in Spain, as we've heard before, almost 55% of the donors in Spain are over age 60. In the US, it's only 13%. And I believe that many of these older and expanded donors could be made available and used in recipients and matched appropriately if we pursue them. The Oliver Weinman report that was sent to the committee shows several methods to increase the number of organs transplanted and shows the model of how to get to 50,000 transplants by 2026 through a partnership of the OPOs and transplant centers. The second thing I wanted to talk about, actually David Goldberg talked about, which was the evaluation of OPO performance. As he indicated, the CMS calc is going to be used to determine donor potential for each OPO. I believe that that's a good thing, that we're being evaluated appropriately, but I think the metric could be improved to actually determine real donor potential at the OPO level. I spent my career trying to evaluate every single year, what is our donor potential? And we published the first paper in 1991 on the Pennsylvania statewide donor study about determining donor potential, and repeated that study in New Jersey, Arizona, and Colorado. I believe to better closely evaluate potential donors, we ought to get down to the patient and hospital level. And I'm requesting that potentially this committee recommend that NQF, the National Quality Forum, which is well established and well respected in healthcare, to establish and improve metrics for potential donors as we go along evaluating OPO performance. I think a third, I believe should be better rules and tools in organ allocation. With the expansion of broader sharing, we need to improve what we're doing with UNOS to be able to expedite getting organs quickly to the right recipient and the right center in as short a time as possible. Organ allocation can take 24, 48, up to 72 hours to get organs placed on one particular donor. This is too long. And we need to find technology that can improve that to match that appropriate organ to the appropriate recipient quicker. And I think with the way we have technology, we can do that with better communication with the transplant centers and the surgeons to improve the organ allocation and matching system. One thing, for example, too, some of the rules right now, transplant centers can accept more than one organ for the same patient from more than one OPO. And often we're faced at 30 minutes before we're ready to go to the operating room, a particular center will say, no, we have a better offer. We're turning your organ down. And the OPO has to start all over again. Rules limiting the number of acceptance should be implemented for transplant centers. And last but not least, Paul just indicated about CMS reimbursement may be changing for organ donation at transplant centers and OPOs. Since 1973, the End-Stage Renal Disease Act, all deceased donor organs recovered in a transplant centers increased the reimbursement calculation for Medicare in those hospitals that had donors and donor organs. Only donor organs transplanted into Medicare beneficiaries will now be reimbursed as proposed. It seems counterintuitive to me that if you want to increase donation, you should not decrease reimbursement for doing organ procurement. Similarly, OPOs are cost reimbursed by CMS for all kidneys procured in donation. And then there will be this alignment that the next will be, the proposed regs will be only for those patients who receive the transplants will be reimbursed who are Medicare beneficiaries. So I think this misalignment should be at this point not implemented and ask for a hold on it till we can look at and evaluate where the reimbursement is going to come from. Thank you very much.
Thank you, Howard. Next is Marty Sellers. Marty, are you there?
Marty, you're muted.
Apologies, guys. That's hi everyone. Sorry. Thank you for the opportunity to participate in this initiative to benefit those on the wait list. They and their families should be the focus of every effort, every decision that we make, and every initiative that comes from our discussion today. I am a transplant surgeon and an OPO medical director, and my comments today are my own and might or might not represent those who lead my respective organizations. But my perspective does result from almost 25 years in clinical practice and having been continuously and actively involved in organ donation awareness efforts and maximizing the use of transplantable organs. I also have a background in public health, and the biggest opportunity we have in this regard is to stop discarding transplantable organs, especially kidneys. Ongoing efforts to increase donation rates are obviously important, but the lowest hanging fruit, if you will, are the organs that we find in our grasp that somehow find their way to the trash. First of all, there's no better example in medicine of what should be a team sport than transplant. The perfect team has individual components whose mission does not counter that of any other. OPO and transplant center metrics, meeting which are necessary for survival for both, are inherently conflicting. OPOs are asked to place as many organs as possible, including ones that are negatively labeled as marginal, extended criteria, etc., while transplant programs are challenged with achieving clinical and financial outcomes that, to say the least, are not enhanced by use of these organs. Those who get transplanted are winners, and the waitlisted who die without a transplant are losers. These losers have had an average of 16 kidneys declined for them by their center before they die. And to think that one of those kidneys would not have been better than dialysis is simply implausible, if not downright silly. In fact, even the so-called winners, meaning those who get transplanted, are transplanted on their 18th offer. Again, it's implausible to think that they would not have been better served with one of those earlier kidneys than that would have decreased their dialysis exposure. These are national data from Dr. Mohan at Columbia and two of my colleagues here at Emory. And while I was not part of this effort with national data, I do have related data from our DSA. 71 kidneys declined for quality during a recent time period for all waitlisted candidates by at least one of our local centers were transplanted elsewhere. The 12-month median creatinine for those recipients that were transplanted elsewhere after these kidneys were declined by everyone on the wait list here was 1.4. 3 of those 71 kidneys failed within a year, but the partner kidney for each worked well. So those failures were all recipient-related events and not due to donor quality. We then found 80 patients who had been offered at least one of those kidneys who eventually got transplanted with another kidney. They waited a median of additional 7 months on dialysis, and the kidneys they received had essentially the same quality. The KDPI was a median of 2.4 lower as the kidneys that were declined for them earlier. And 46%, almost half, did not receive a lower KDPI kidney. Similar to other national data published by Dr. Mohan, a disproportionate number of these declines were declined on Friday. And almost all of those Friday declines were declined before cross-clamp. So before pump data, biopsy data, all the information that you would need to assess a kidney was known. Now some thoughts on change. Transplant centers should become judged and held accountable more by what happens to patients on their wait list than what happens post-transplant. So post-listing survival as opposed to post-transplant survival. This is a comment we made in a paper from almost 20 years ago. This would certainly lead to a more effective system from a wait-listed candidate's perspective. From an efficiency standpoint, and in the interest of time, I'll just draw your attention to an article in the November 2019 issue of HHE by Mankowski and colleagues at Johns Hopkins, who advocate for simultaneously expiring kidney offers. It would almost certainly decrease kidney discards and align OPO and transplant center interest, as well as those on the wait list. Artificial intelligence, I think Howard mentioned or alluded to the technology. I think we have the technology, we have the data. I think AI should replace the current system to assign a donor kidney to a recipient based on quality of the kidney, perceived benefit to the recipient, and distance that the kidney would have to travel to get to the recipient. The on-call surgeon at that recipient center can still decline if they want, but for those that are declined and transplanted elsewhere, that recipient should be notified that a kidney was declined for them and transplanted to someone else lower on the waiting list, and therefore they have to stay on dialysis while their counterpart lower on the waiting list is now transplanted. Perhaps even an OPTN patient portal where they can log on anytime they wish to see the cumulative data and real-time data that applies to their individual self. Now, to be fair, there are recovered kidneys that probably should be discarded. Not every recovered kidney is probably well advised to be transplanted. But
Marty, could you begin to wrap this up?
Yes, a couple more sentences. The entire transplant community can do better than the consistent 20+% that have been discarded over the past several years. That finishes my comments, and I thank you for the opportunity to participate in this discussion.
Thank you for your comments. Our last speaker in this session is Janice Starling.
Yes, I'm here. How you doing today? I was just like, wow, I got on in time. Yes. Hi, how is everyone doing? I just wanted to let you know that I was a transplant patient. I was on dialysis for 14 years. I did all modalities. I waited so long because of my high antibody level. I had no idea about the kidneys and the extra donors or disregarded kidneys. I was on 3 transplant lists. I was on Tampa General, Miami, and Shands Hospital. But I had no idea about the disregarded kidneys that I could have had. Now, I do remember when I got to my 13th year, when I went for my review, a young man came, my doctor asked me, would I be willing to get a kidney that wasn't the best kidney? And at this point, I was like, just give me whatever I can get, because I had waited so long for a transplant. And one of the things that I feel that if patients had the opportunity to know about kidneys that they could have had, or maybe I could have had a kidney sooner, or I could have had one, earlier, I wouldn't have to wait so long. So I just feel that we need to have some type of program or something. I like the idea what he said, a portal maybe that we could go on and maybe have a chance to choose. I do have a lot of friends that are still waiting on kidneys, and they're still waiting. And one of the things that I know is it's such a high priority for you, the money to make sure that you can afford a kidney transplant. They make it such a big issue here in our part of the United States that a person has to be able to afford it and must have the insurance. And they try to get people to raise money. So at the beginning, before a person can even get a transplant, they have to show that they can afford to have the medicine when that's not the issue. So I don't know why is it such a big deal here. I don't know if it's like that all over the world. I mean, in other states, but here in Florida at some of our transplant centers, we have to do that. Any other questions you would like to ask?
Thank you, Janice, for your comments. Appreciate your being with us today. That wraps up all of the scheduled speakers. We're a little bit over time, but I would ask the committee if they have any clarifying questions that they'd like to pose to the speakers at this point. It's time to do that before we move on to the next session. Alex?
I wanted to ask Dr. Sellers, I thank all the speakers, all very informative. You highlighted something about the systemic approach among OPOs and transplant centers and the disjunction between their interests. I wonder if there are a couple of other disjunctions that are worth looking at. And your comments, one is the geographical disjunction that arises because of donor service areas. And the second is what you hinted at was a chronological disjunction. Deaths occur continuously, patient need is continuous, but when Friday comes, you were suggesting that the data show that transplants are not chronologically continuous, they're disjunctive with the weekend. What do you think of these disjunctions, and what would you do about them as a person in surgery and with an OPO?
No, those are excellent points, and I think the weekend data, and again, this has been, we've not published our data yet, but the weekend data is a nationally published phenomenon already, and it's frankly an embarrassment, I think, to the community. I will say, based on the kidneys that were declined by, again, at least one of the local centers in our OPO here, we'll just say thank God for the University of Miami, because they took a disproportionate number of those kidneys and transplanted them into patients who again, if you remember the data, did quite well. I mean, a median creatinine of 1.4 at 12 months, that's basically a normal, that's normal kidney function. The geographic distances, honestly, that's a disconnect that I think it is what it is. I don't know that it can be accounted for. I think we can probably refine the system to account for that. And again, AI can, I think, assign the right kidney to the right person with that as part of the model. I mean, an almost perfect kidney for someone in Miami from a donor in Seattle might not be worth the distance if it's also an almost perfect kidney for someone closer. But I think that the data exists and the technology exists for us to do that. And I think no one wants to be overly regulated, but transplant centers, and Jamie Locke said this morning, the OAR, the offer acceptance ratio, is not something that's considered as much as it should be. And there are issues with that. And you can look at even at my center, our acceptance ratio is not what I think it should be, but there's some sort of rationale behind that. And that leads into other discussions about the efficiency of the filters that you put in. I mean, why are you getting, 15,000 offers a year if you're only going to take 20? And, artificial intelligence can also use a program's acceptance history. I mean, if you've never accepted a kidney from a 65-year-old person with diabetes, then you don't get this offer. But I think, again, that's something that the patient, and I think Janice would agree with this, the patient should know if their center is going to be turning down all these kidneys automatically, then I might want to be listed at another center. But that, again, exposes the geographic issue, because if you're in rural Midwest, you don't have access to 15 transplant centers like you do if you're in Manhattan. So a lot of the way I look at this is it's a multivariate problem that we are not going to solve with a univariate solution. Focusing on OPO performance is, I think, a worthwhile thing, but it's not worthwhile in the absence of focusing on the other aspect of transplant community, meaning the transplant centers.
So Renee, it looks like you have your hand up as well.
Yes, so I wanted to follow up on Alex's question to Dr. Sellers, because I guess one of the thoughts that's occurred to me as we've been talking about this, as our group has been working on this, is whether, the system, the transplant centers and the payers need to invest in multiple teams of people so that this weekend problem does not happen. And so I'm just wondering what you think about that.
Yeah, and that's, again, opens up, I think it exposes another area, because if we're going to be incentivizing places to transplant these more marginal or, again, I hate the pejorative term marginal, expanded criteria, et cetera, but because, again, like Janice said, and they're better than dialysis. They may not be the perfect kidney, but they're better than dialysis. They're BTD kidneys, I guess. And maybe Paul would be a good person to respond to this. The transplant center financial, outcomes are not enhanced by taking kidneys that are going to be on dialysis for another, 2 weeks before they start working. So that interferes with your profit margin from a transplanted, for a patient that gets transplanted. And I have personally been involved in transplants when I'm not on call on the weekend, and I'll be happy to come in and do the transplant, but we don't have a team in the OR to do it. So it doesn't make, it doesn't align with the waitlisted patient's best interest. And I think if we keep the waitlisted patient as our North Star, or the front and center of our radar screen, then those, those changes can be easily justified. But if you look at it from a financial perspective, they may not be so easily justified. To pay people to be on call all the time on the weekends, might not be financially feasible, just because you don't have, you'll have some weekends where you're less busy than others. But as has been stated, biology doesn't know Friday versus Tuesday, and deaths don't happen more commonly on Tuesday versus Friday. So it's again, there are multiple issues involved that I think all need to be just, if you put aside your own agenda and focus on what's best for the person on the wait list, then you make the right decision.
Thank you, Marty. We're going to have to move on. We have 10 more speakers in the last hour. So we want to shift the focus of our comments from how we increase the efficiency and effectiveness of the system to now look at how we increase rates of organ donation and acceptance, basically what could we do to save more lives of people who are on the wait list? So with that, let me ask our first speaker. I understand everyone is here. Jennifer Erickson.
Americans' generosity towards organ donation is not matched by accountable systems, and 33 people die every day as a result. My name is Jennifer Erickson, and I'm a senior fellow at the Federation of American Scientists. I worked on organ donation in the Obama White House, and my work has been supported by the Arnold Foundation and Schmidt Futures, two philanthropies with no financial interest in this space, just a desire to follow data. The work of OPOs and the OPTN is critical. Both should be run by the most innovative, accountable organizations because when they fail, patients die. Patients of color are particularly disadvantaged, and COVID will exacerbate this. As ACLU board member, Professor Michelle Goodwin has said, this is about exclusion and death. And the answer is transparency and accountability. I focus on OPOs and the OPTN because these are monopoly government contractors. The American public is paying, and it deserves to know what it's getting, especially given the executive order on competition. When a contractor fails, it should be replaced and new leadership brought in. There is plenty of bandwidth in the system, but this has never, not once in decades, been the case. The LA OPO had to return more than $500,000 in 2010 after billing Medicare for Rose Bowl tickets and five-star retreats. The OPO kept its contract. In 2012, the Alabama OPO leadership went to federal prison for a multi-million-dollar kickback scheme. The OPO kept its contract. Most troubling and deadly, the government has identified OPOs across the country failing to recover thousands of organs every year. In Virginia, 117 transplanted organs were required to meet Tier 1. Put another way, 117 people died. 173 people died due to the North Carolina OPO's underperformance, 184 due to Kentucky, 211 due to Miami. I could go on, yet no OPO has ever lost a contract, and the average compensation of a failing CEO is more than $500,000. Meanwhile, UNOS tech has been called antiquated. In recent years, 17% of kidneys were offered to dead people. So transparency. House oversight highlighted that data that 7 leading OPOs have agreed to share publicly should be required of all, including every referral, with breakdowns by race and ethnicity. The OPTN should have similar transparency. Kaiser Health News identified 191 organs in recent years lost in transit. And every time that happens, there should be an immediate public record. Disclosure is critical. The public deserves to know about conflicts of interest and undisclosed payments. A good start would be for all members of this committee to publicly disclose their business relationships related to organ contractors, tissue businesses, and trade associations so that the public can be aware. And then NASM can recommend similar disclosures for all executives who work for government organ contractors. Otherwise, there is no way for this committee to make valid recommendations in this area. Second, accountability. There is a lobbying campaign to roll back the patient-centered OPO final rule. You've heard about it today, endorsed by 2 administrations. As a former White House official, I can say the alternative proposed, electronic medical records, is unworkable. Whether those proposing this are intentionally offering a poison pill, I don't know. But now NASM knows that CMS has said it would not be feasible. To advocate for an unworkable standard is to leave patients to die in an unaccountable system. In February, Dori Segev highlighted system failures have been studied for years. Patients need action. Patients across the country deserve to be served by high-performing OPOs based on data available now, and for the OPTN contract next year to be truly open, attracting the most capable innovators possible. Apologists will say reform should not be about blame, that we should seek consensus from the very contractors and trade associations that are conflicted and have failed to fix the system for years. But it isn't the lives of contractors who are at stake, patients are. Contractors who deliver based on transparent, objective data, they save lives, and those who don't cost lives. Further study or presumption of goodwill toward known failure is an abrogation of responsibility. Ben Jealous, past president of the NAACP, was right. If we understand the problem and know the solution, to withhold its implementation is cruel and senseless.
Thank you. Next speaker, Richard Formica, and forgive me if I mispronounced your last name.
No, you got it right. My name is Richard Formica. I'm a professor of medicine surgery at Yale University, and I am the past president of the American Society of Transplantation. The American Society of Transplantation represents the majority of the nation's professionals engaged in the field of solid organ transplantation, with over 4,000 professional members of the organ donation and transplantation profession, and representation from the patient transplant community through our Power to Save patient education efforts. We appreciate this opportunity to address the national academies and participate in this public listening session. The following 4 recommendations are the considered recommendations of the American Society of Transplantation. Recommendation number 1, demonstrating respect for deceased donor families. The AST believes that words matter, and the recent national debates around organ donation, donor potential, organ yield, etc., presents the deceased donor as a supply to be maximized, when in reality, organ donation is a resource, a gift, a benefit to society at large that is a result of altruism of members of the same society. Deceased organ donation requires complex and sensitive human interactions. OPO staff must have difficult conversations with the families of potential deceased donors at a time of intense emotional stress. These discussions will be easier and will more likely result in donation if the public at large has a favorable view of organ donation and the system responsible for coordinating it. Therefore, the AST recommends that messaging regarding organ donation, OPOs, and the construction of policy regarding organ donation be done in a sensitive, culturally focused manner that avoids terminology that dehumanizes deceased organ donors, commodifies donated organs, or degrades the trust in the system at large. Recommendation number 2, alignment of donor hospital incentives with those of society. The AST believes that the success of organ donation requires active engagement by donor hospitals. The AST believes that the process is most successful when donor hospital leadership and the hospital care team champion the mission of deceased organ donation as part of the continuum of care of a patient, and when there is an alignment of incentives. The process of successfully recovering donor organs requires donor hospitals to devote resources to identify, obtain consent, and medically manage deceased organ donors. Therefore, the AST believes that reimbursement policy should be aligned with the goal of maximizing donation by compensating donor hospitals for efforts to recover organs from potential donors, regardless of the final disposition, such as the donor not progressing to donation or the organs ultimately not being utilized for transplantation. Recommendation number 3, development of valid metrics to inform the quality of deceased donor services. The AST understands the need to advance the development of new metrics to help improve deceased donor services provided by OPOs. However, the AST does not endorse a disruptive approach that has the potential to destabilize our already high-performing system at large, and that does not comprehensively assess factors that limit the availability of organs for transplantation. Increasing organ transplantation requires a comprehensive system-wide strategy inclusive of improved OPO performance metrics that can produce reliable benchmarks. Therefore, the AST recommends a consensus-driven process that involves all stakeholders to develop objective and reliable metrics for the quality of deceased donor services. These metrics should be used to improve the practices of all OPOs and in alignment with other system-wide metrics with the goal of delivering better access to transplantation for patients with organ failure. Recommendation number 4, alignment of metrics used to evaluate organ procurement organizations and transplant centers. The AST believes that organ donation and transplantation are interdependent. Therefore, to save more lives, the focus must be on the whole system as opposed to its individual parts. The construction of metrics to evaluate the performance of transplant programs and organ procurement organizations in isolation contributes to an environment where transplant program incentives and OPO incentives may be in conflict. This conflict prevents maximizing system performance for the benefit of all patients. Therefore, the AST recommends a holistic approach to the formulation of the transplant system metrics that considers the interdependence of transplant centers and OPOs in ensuring optimal organ donation and transplant practices. Thank you for this opportunity to address the committee.
Thank you for your comments. We're going to now turn to the other Kevin on the program, Kevin Longino.
Hello, thank you for having me. My name is Kevin Longino. I'm the CEO of the National Kidney Foundation. I'm also a kidney transplant recipient of 17 years. Our motivations at the NKF are simple. 12 kidney patients die every day on the wait list, while 9 kidneys are discarded every day. I believe if we focus more on the issue of discards, we're going to find a lot of opportunities for improvements in the system that are going to lead to more transplants system-wide. 20 people a day are told they're no longer eligible for the wait list, they're taken off, and thousands are not even given the choice to transplant, particularly disadvantaged communities and particularly African Americans. I've got essentially 5 themes that are interrelated and weave throughout our recommendations. However, we will be submitting more detailed and more specific written recommendations that go well beyond this list. But those themes are transparency, shared decision-making with patients, risk mitigation for transplant centers, innovation, and reducing barriers to living donation. So in the area of transparency, there was an article in CGation in 2017 that showed among patients that receive an offer, 10% die without getting a kidney. Another 20% are removed from the wait list. In fact, the data went further to say that patients who die on the wait list received a median of 16 offers over a 2-year period, and yet they died. The average number of offers that a patient gets before they receive a transplant is about 17. So if you can make it to 17, you got a shot at not dying and getting the kidney. Now, I can tell you that patients don't know this. They don't know how many offers are being made on their behalf and turned down on their behalf. And when they do, and they hear these stats, it leads to significant issues of trust in the system. Another statistic is that the median number of declines is 7 times before a kidney is accepted. In fact, 86% of all kidneys are declined at least once. And it makes one wonder the effectiveness of the allocation system. Now, this is all based on a JAMA paper from 2019. There's been some changes to the allocation rules since then, so I'd be curious to see if that's improved. But what the transparency problem leads to is the opportunity for shared decision-making. Patients need to be more frequently brought into the discussion about what quality kidney they're willing to accept. Now, many programs do this upon listing. They sit down and they educate the patient on Hep C, on high KDPI and what that means, on other things that impact the quality of the kidney. But this is not frequently revisited with the patient. Patient preferences change. If you've been on dialysis 5 years, your point of view is considerably different than someone that's just hasn't even been on dialysis yet. So what we need is quality measures along these lines, where we're constantly doing some kind of review with the patient, understanding where they're at, what their preferences are, how they're doing on dialysis, and what their lifestyle needs are. And they might be willing to accept something higher, a higher KDPI kidney or Hep C or something like that. So we also need to get at the transparency issue. We need a transplant center metric of organ offer acceptance, something that everyone can see and we can talk to and support improved shared decision making. Another theme is risk mitigation for transplant centers. Transplant centers are often risk averse, and this is contributing to high discard rates and potentially lower recovery rates by the OPOs. Now, this is all because the DRG is a fixed payment. It doesn't matter the quality of the kidney. It's a one-size-fits-all payment system for Medicare and similarly from commercial payers. We all know that kidneys that have an 8-hour cold ischemia time are very different than a kidney transplant that has 30 hours cold ischemia time. High KDPI kidneys run the risk of longer hospital stays due to delayed graft function, increased use of dialysis, et cetera. We don't have the right economic incentives for transplant centers to take on these kidneys. We also have the wrong quality measure. Patients do not care about a 1-year graft survival. And yet that's the key metric that transplant centers are paying attention to. It's too restrictive and it's getting in the way of transplant centers being able to take on a less quality kidney. And then lastly, but related to the reimbursement issue is that innovations. There's a lot of innovations. In fact, the National Kidney Foundation is holding a delayed graft function conference in November. Many therapeutics are now available or are coming on the market that could improve the issue of delayed graft function. However, there's a lot of uncertainty among these businesses, among the venture capital and private equity, whether they're actually going to get reimbursed for these new innovations that could affect the yield and affect our ability to take on higher risk in the transplant center. So again, we've got a reimbursement issue. And then lastly, reducing barriers to living donation. We need more patient engagement and empowerment with programs like ours of the Big Ask Big Give. We need to also increase the eligibility caps for funding and access for NELDAC. We need to enact the Living Donor Protection Act. Finally, we need to get that done this year. And we need to create the right tax incentives for employers to support living donation through their employee population. And we need employers to support living donors in any way possible and make that a standard benefit of their benefits package. So thank you for your time and for hosting this. And I hope you remember that the real issue is 12 people are going to die today on the wait list as we continue to try to do reform. Thank you.
Oh, Ken, you're muted, I think.
All right, let me try that again. I apologize to Kevin Fowler. My glasses, I think, were not functioning correctly, and I skipped over you by mistake. And again, I apologize and went directly to Kevin Longino, but we're going to go back and hear from Kevin Fowler.
Yeah, no need to apologize. Thanks again for the opportunity to speak today. My name is Kevin Fowler. I live in St. Louis, Missouri. Professionally, I work with companies that are developing treatments for kidney disease and kidney transplantation to bring innovation. Been living with a kidney transplant since August of 2004. And I have 4 recommendations to this conversation. My first one is the patient voice. Within transplant, the patient voice is not really engaged in a systematic manner. And I think that I think this has implications in terms of disparity, but as Kevin just mentioned earlier, innovation, there's lots of innovation coming to transplant, but if the patient community is not aware of this and engaged with this, this innovation is not going to come to the marketplace. So there's a huge opportunity there. The other part about the patient voice too, and I would just kind of go back to what Michelle Goodwin said earlier too, is making sure that you have the equitable voices, the people that represent the community. I would encourage you to learn about the Kidney Health Initiative Patient Family Partnership Council. It's intentional behavior that led to diverse representation. I really shouldn't say diverse, they just really represent the people who have kidney disease. So it can be done, it has to be done intentionally. If you're also looking for another example to incorporate the patient voice, look at the Kidney Precision Medicine Project. But I think the absence of the patient voice is going to limit innovation, it's going to further disparity, and it's going to hurt the field. The second one, I have to go back to what Dr. Gaber said, is that, yeah, we have had a system of dialysis, and the resources have all gone toward dialysis for the most part. So I think one starting point is that the people that enter dialysis should be educated on the risk of dialysis. That's not happening. I would encourage you to look at the work done by Dr. Ann O'Hare, where people who go on dialysis have a overinflated sense of how long they're going to live. And there's also a lack of quality of life. If people are informed of that risk, then I think they can then start making better treatment decisions. But right now, that's a starting point that needs to take place immediately. The third area that I would say too is then looking at the whole area of education. I think the Medicare education program, which is not utilized that extensively, requires a overhaul because of the fact that the system that we have is no longer just dialysis or kidney transplant, but it's also looking at paired donation, it's looking at discards. So the whole overall education system needs to have more teeth into it, needs better reimbursement, it needs to be measured for effectiveness, and it needs to reflect the changing field of transplant. And then secondarily, I would also make the point, the importance of early detection of kidney disease. If we keep people with their kidneys, we're taking pressure off the system. And so that still is something that nephrology community has not embraced. And my fourth point, and I think my fourth point is just in fairness to the transplant centers with Dr. Formica and Dr. Gaber on here, is that they've been operating with one arm tied behind their back. They haven't had the resources to succeed. So if we're going to go ahead and increase rates of donation, resources need to be allocated to ensure the success of those individuals. So to be fair, if we look at our system, and I know NASM is looking at this too, people that receive a kidney transplant many times are not rehabilitated. I've been fortunate, Kevin's been fortunate to be rehabilitated from our transplant, but I can share with you my first year of transplant was a struggle. When I went to find answers, I couldn't find them. I found them on my own. But I would just say if we go through all this effort to increase transplants, and we don't put transplant centers in a position to succeed, nor the patients, that fundamentally needs to change. And so I think that, like Dr. Formica said, all these areas need to be aligned. And my final comment, what is really missing in transplant, I watched those OPO hearings and I was incensed. Where is the humility? There's a lot of smart people, but humility is sorely lacking. And I think if we get back to understanding why this is all work is being done and making the patient voice a priority, things will change for better. Thank you very much for the opportunity.
Thank you, Kevin. Next speaker is Gerald Mann.
Thank you for the opportunity to share my views on much needed and long overdue organ donation and recovery reform, the work of this committee. This is an issue for which I have deep and decades-long experience. In the early 1980s, as a legislative assistant for then Representative Al Gore, I led a multi-year investigation and helped write the National Organ Transplant Act and subsequent organ transplant laws. NOTA established the organ procurement organizations and the Organ Procurement and Transplantation Network. At the time, our goal was to create a national system that would ethically pursue every transplantable organ every time one might be available and lead to as many viable organ recoveries as possible, significantly and fairly increasing the number of successful organs transplanted to improve and save lives. Unfortunately, the infrastructure we put in place has not yet achieved its intended goal, and the U.S. Department of Health and Human Services, the Center for Medicare and Medicaid Services, and the Health Resources and Services Administration have shared much of the responsibility for this shortcoming. Over the past few years, I've been encouraged and relieved to see Congress, now successive presidential administrations, the press, and this committee taking a harder and more critical look at OPOs and OPTN reform. Allowing OPOs to operate as a network of under-accountable monopolies has too often created a culture of complacency, inefficiency, and underperformance. OPO transparency and oversight are critical because of the reimbursement structure for OPOs. When we passed NOTA, we supported Medicare full OPO cost reimbursement to ensure that costs would not stand in the way of organ recovery. But in return for cost reimbursement, we expected careful oversight. At the time, OPOs were a $100 million annual industry. Today, it is a $3 billion industry, and oversight still remains sorely lacking. Vigorous HHS oversight is essential to our organ recovery system. Cost reimbursement ensures we attempt to recover more organs, save more lives, and improve the quality of life, but it is subject to abuse, and we worried it could lead to excessive salaries and expenses that have been documented at some OPOs. Perhaps more importantly, cost reimbursement has not been sufficient to ensure OPO effectiveness. Objective data from the robust noted data systems we created reveals OPO performance still varies by almost 500%, which is clearly unacceptable. The strategy almost 40 years ago and still today is if all OPOs were as effective as the most successful OPOs, thousands of more organs could be recovered and lives transformed. Instead, we have $500,000 OPO CEO salaries, but many OPOs remain sorely understaffed on the front lines, the critical roles for talking to families about donation, and have not made basic investments in modern technology. Additionally, the OPTN, the contract held only ever by the United Network for Organ Sharing, has too often failed to provide the necessary oversight for OPOs. UNIS has been characterized by the Los Angeles Times as a reluctant enforcer. We established the OPTN as a membership organization run mostly by transplant professionals, stakeholders, and affected families as a sacred trust for those most involved and impacted to join together to set the required policies for an effective system. We understood the risks of that model, but counted on a thoughtful public leadership from HHS, CMS, and the leaders in the field to ensure the public interest was served. However, HHS, CMS, and HRSA have not provided the expected oversight. Instead, we have allowed federal oversight to slip through the cracks, and no one agency has truly felt both responsible for and empowered to clean up the clear abuses and chronic underperformance of the OPO industry. As the New York Times editorial board wrote, and I quote, an astounding lack of accountability and oversight in the nation's creaking monopolistic organ transplant system is allowing hundreds of thousands of potential organ donations to fall through the cracks. When we passed NOTA, we had expected that organ donation responsibilities would be consolidated within the office of the HHS Secretary. This was critical because CMS pays the bills but is unable to manage the donor system day to day. We were disappointed by the decision to place a division of organ transplantation within HRSA, which from day one, given its many and varied mandates, has seemed unable to make it a priority and, probably more important, leverage CMS's investment. It is perhaps unsurprising then that OPO underperformance has persisted unremediated. Thus, I'm deeply heartened by HHS's January announcement of its intention to move the Division of Organ Transplantation and along with it oversight of the OPTN to the Office of the Assistant Secretary of Health. The facts that I have cited shows how critical your leadership is now in helping reform the system in patients' interest. While we were operating in good faith and on the best information available to us at the time, there is no question now that the OPO industry must do much more to serve the public interest. The federal government has to step up its oversight, accelerating OPO reforms to ensure that the public is served by high-performing OPOs and that the OPTN benefits from basic competition and innovation in the upcoming contracting cycle. And HHS should take responsibility to oversee its contractors and agencies via an elevated office within HHS. Again, thank you for this opportunity. I wish you success in this important task, and I'd be happy to answer your questions.
Thank you. Our next speaker is Melissa McQueen.
Thank you so much for having me. It's an honor to speak to the National Academy today. My name is Melissa McQueen. I'm mother to a transplant recipient who is now 13 years old, founder and executive director of Transplant Families, and I hope to speak for the pediatric transplant groups. I'd like to applaud many of the previous speakers for calls to transparency and objectivity, and I'd also like to echo concerns about discard rates and long-term survival statistics. These will certainly be important going forward and reducing the amount of organs we have in need. Also like to say that I'd like to focus on some of the positive metrics showing increased donations since 2012 and would like to see much more innovation utilizing the patient and family voice and patient and education. But as far as innovations go, there's so much going on and so many opportunities. I've been fortunate to work with a number of quality improvement organizations and see how even getting to transplant, to getting an organ failure and avoiding being listed is a huge part of the process. But when you're there, there's definitely a lot that can be done in that area as well. So finally, I'd like to say, as far as the OPOs go, I've been very interested in hearing everyone's comments. I do want to say that even though there are some that aren't, may not be great, I think it's not fair to all of them. There are some that are very high performing and great people. There's a lot of wonderful people working in the OPO system, dedicating their life to this, to saving lives, to helping others, to telling the story that helps others sign up to be organ donors. And that's a huge part of it. Any kind of awful press goes against what we're all trying to do. I want to say that maybe we take a cue from some of the quality improvement collaboratives and take some of the best practices of some of those really great OPOs and try to transcend that down to all of them. I thank you for having me speak today, and I've just been really great to hear everyone talk. Thank you so much.
Thank you, Melissa. Our next speaker is Patty Niles.
Thank you and good afternoon. I appreciate this opportunity. I am Patty Niles and I have over 30 years of experience in working in the organ donation field. In 2013, I joined Southwest Transplant Alliance, the OPO in Dallas, Texas, as their CEO. At that time, we were considered a pretty good OPO. My team learned that I was looking to go from good to great. And as I looked at our new numbers, I saw a grave need for improvement. No one knew that we were grossly underperforming because our conversion rate and metrics were totally acceptable. In 8 years, we have moved from 731 to over 1,300 organs transplanted. an 80% increase. And these are not just numbers, they are lives saved. And it wasn't that we found new donors, it was that we implemented a new process to assure we captured more opportunities. It was about leadership. But my point here is there was no metric that was highlighting our failing OPO. Patients are dying every day, and it's our duty to be transparent and accountable, and that's with data to the communities where we serve. The US, as you've heard, is recognized as having one of the highest performing transplant systems in the world, but reform and systemic changes are necessary to bring every OPO to a high performing program. A failed and conflicted oversight of our system has allowed too many individual hospital systems, transplant programs, and OPOs to woefully underperform over the years, and that's not acceptable. This has resulted in thousands of lives lost and billions of taxpayer dollars wasted, and this must come to an end immediately. And Medicare's new performance standards, while not perfect, they are a necessary first step to fixing the problem. Other than the number of organ donors and organs transplanted, there's still no standardization of data or definitions among OPOs. Over the years, I've heard over and over, if you've seen one OPO, you've seen one OPO. This is often said playfully, and I've enjoyed that, but highlights a real problem, a huge problem. Collectively, our industry has accepted that we all do things a little different, but how can we possibly accept the unnecessary deaths that result from OPOs who underperform? It might startle you to know that HHS data reveals a 470% performance variability between the highest and the lowest performing OPOs. The performance gaps seen in the OPO community would not be acceptable in any other sector of healthcare. There is no reason to accept them in the life and death context of organ donation. The problem historically has stemmed from a lack of objective and transparent data to evaluate OPO performance. For as much as OPOs talk about our commitment to best practice sharing, the truth is that we don't actually have reliable data because we, the OPOs, define and count our internal metrics differently. OPO data is self-defined, self-interpreted, self-reported, and non-standard. For example, OPOs define an authorization, donor eligibility, donor potential, and even what a donor is very differently. Without these fundamental definitions, we will never identify our performance opportunities. HHS's OPO rule, which our OPO supported, offers a great solution for standardizing OPO outcomes, but we can't stop there. I see a huge opportunity to focus on process data. Imagine with me a waterfall, at the top of which we have a standard and reliable accounting of each OPO's actual donor potential. So from that donor potential, we can then quantify the drop off for each OPO at each process point. I've worked toward this goal for years, most recently spearheading a data task force with the OPO membership. Unfortunately, basic standardized definition and data benchmarking have yet to be accomplished with consensus. I've come to the conclusion that definitions and requirements for process data transparency must be imposed on OPOs by CMS. STA recently joined 6 of our OPO colleagues in partnership with the Federation of American Scientists in committing to full data transparency. This committee has a powerful opportunity to build on these transparency commitments. We need standardized definitions and enhanced transparency requirements for OPO process data, and I strongly encourage you to seize it. The patients deserve better, and the waitlist can't wait. I serve as a resource should you have questions. Thank you.
Thank you, Patty. Our next speaker is Velma Scantlebury. Velma?
Sorry. Good afternoon, everyone. My name is Velma Scantlebury. I'm a transplant surgeon practicing in over 30 years. So thank you for the opportunity, and thank you, Patty, for your words. And we are all aware of the increasing number of patients being added to the wait list every day, and the greatest need of those being for kidney transplantation. the rise in patients awaiting organ transplants is really not matched by the rise of deceased donor organs. And so we know that the need continues to be great. We also know that patients of color on the waiting list continue to increase and now represents greater than 50% of those awaiting kidney transplant. However, we need to recognize the fact that there's need to be a greater focus on education and increasing organ donation within the Black and Brown communities. We also need to recognize that these communities exist and value their ability and the need to be organ donors. However, one of the major components to organ donation continues to be the reluctance to donate due to mistrust of healthcare system. We need to have a better focus by OPOs to hire and use culturally sensitive and competent outreach personnel to address the issues and concerns around organ donation within communities of color. It should also be transparent from the OPOs what percentage of declined potential donors are donors of color. And as they recruit or cite numbers of organ donors, how many of those are from communities of color that decline to be donors? When we look at the pre-COVID donor rates for states such as New York, we find that for 2019, there were nearly 450 kidney donors listed on the UNOS database, with 276 of those from Caucasians, but only 73 from African Americans and 88 from Hispanics. And we know that such a state, especially within the city area where there are multiple transplant centers, that there are thousands of people of color within that state. And so it's important that OPOs and transplant centers should be working together on a collaborative effort to provide outreach and education to communities of color with the important culturally sensitive educators to get that information across and decrease the reluctance to donation within such communities. My second point surrounds the ongoing concerns and publications of discard of organs. But while OPOs push to get organs transplanted, transplant centers are focused on using those organs to provide, as we heard from Dr. Gaber, the right kidney for the right patient. And the offer of kidneys with high KDPI, abnormal biopsies, by transplant centers is focused by ethicists and statisticians without considering the possibility of failure of that organ. A patient who now waited 8 to 10 years and now has to return to dialysis and start all over again because that kidney didn't work. And certainly the oversight of transplant centers and the need for transplant metrics can limit a center's ability to use such marginal organs. So surgeons focus on that right organ that will provide the benefit for a patient compared to dialysis and death on dialysis, or compared to surviving just 12 to 15 months after a transplant, with the penalty of losing their wait time and having a kidney only to return to dialysis after a year or so. But not all organs that are discarded are suitable for transplantation and will not benefit all patients. And we also need to remember that many discarded organs are organs removed from patients despite being turned down by all transplant centers and are retrieved despite the severe abnormalities that are manifested. We must also acknowledge that many patients who die on the wait list likely do so from cardiac disease or conditions that are not related to not being transplanted, but maybe related more to being on extensive years of dialysis. Perhaps the focus should be on getting patients better access to early diagnosis and listing and avoiding years on the wait list for a kidney. So I urge you that while arguing that more use of discarded organs is out there, consider the outcome of using a kidney for the wrong reason and the penalty to that patient who receives that kidney. If you are that patient, would you want a kidney knowing that there's considerable abnormalities or that that organ may not last more than a year or so? So thank you for the opportunity to voice my concern and to give my thoughts on this matter.
Thank you, Dr. Scanberry. Next speaker is Quinn Taylor.
Hello, happy Thursday, everyone. My name is Quinn Taylor, patient advocate, consultant, and speaker. I want to thank NASM for this opportunity to help amplify the patient's voice. I've been on the journey of managing chronic kidney disease for almost 20 years now. During this time, I've had the opportunity to encounter some of the most gracious, compassionate, and kind doctors, nurses, and care providers in general. I often find it difficult to find and try to put into words the gratitude I feel when I receive care that revolves around me being a human being in a vulnerable state that needs help. Healthcare should be human care, and we should all strive to ensure that it is a human experience. In identifying that human experience, it sheds light on a point that is very poignant and can be applied in various parts of life, and is often a very sobering idea. As humans, we aren't perfect. The beauty of imperfection is that it allows us the opportunity to improve ourselves, systems, and processes. In the brief time I have today, I want to share my journey with transplantation and why improvement is necessary in getting more individuals transplanted. When we plan our lives, I don't think anyone voluntarily writes their narrative to include organ failure and go through the process of receiving an organ transplant. I certainly know I did not. I have a rare kidney disease, FSGS, focal segmental glomerulosclerosis, which is when the kidneys are inflamed and they develop scar tissue over the filtration system and they fail. I was diagnosed with CKD at the age of 20, and I began dialysis at the age of 27. Because I was young, I was advised to get a transplant, but I didn't qualify to get listed because I was overweight. Having to be the leader in my journey to transplant, because when you aren't a potential candidate, you get lost in the cracks. I had to be the leader. I went through a 3-year journey of working out and eating right just to lose weight, just to get an appointment, to get the workup to be listed, potentially be listed. It was hard work, and it was one of the hardest things I've had to do in my life. Humans needing organ transplants face the obstacles of jumping through hoops just to get listed. As we navigate through this journey, we're often faced with infamous finger pointing of who is responsible of guiding you through. That is enough to make a person want to give up, because you don't feel like a human anymore. You feel like an object on an assembly line that's disposable and rejected. Being on dialysis and was beginning to wear on my body while I was trying to keep up this lifestyle to maintain my weight loss so that I wouldn't be taken off of the list and have to end up waiting longer for a kidney transplant. People asked me what kept me motivated, and it was an idea of receiving a life-saving organ transplant to not only improve my quality of life, but also to save my life. As of this morning, UNO shares that there are 106,999 people who are waiting for a life-saving organ transplant. Of these people, 64,963 are active waiting list candidates. Imagine living every day for weeks, months, and years, waiting for one life-changing moment when you receive a phone call that you're getting a second chance at life. These people are waiting, fighting, holding on to hope. Around 20 people die every day while waiting on this list. Speaking specifically about kidney transplants, 20% of donated kidneys are discarded every year. There have been many innovations made in the world of transplantation that allows kidneys from donors with pre-existing conditions such as hepatitis C and HIV to be transplanted to increase the number of people who can be saved. Yet transplant programs are rejecting high-quality kidneys. Humans waiting for transplants rearrange their lives to make themselves available to receive that one phone call. But data shows us that kidneys that are available on weekends are the top of those discarded. Where does transparency come in? As a patient that is praying, wishing, and suffering while waiting for an organ, why don't I have any input or knowledge about these viable organs that are rejected and discarded while I wait? For the listing process to the transplant process, improvement must happen and is necessary. This is a human life issue, and we can't afford to keep ignoring this. My hope is that this conversation can be the catalyst to work towards change, and most importantly, increasing the lives that are saved. As a world, as a country, we've seen the devastation that can happen when there is a lack of transparency about healthcare and when processes provide more barriers than resources, especially in communities with Black people and Indigenous people of color. We've also learned together about something called gratitude. Every day when I wake up, I thank God that I get another day on earth, that I've been given extra time to see my mother smile, to laugh until I cry, and to live out my purpose of helping others. We've had a humbling reminder that tomorrow is not promised to any of us. When people make the selfless decision to donate their organs, we shall honor their legacy and treat them as the treasures they are. Everyone who is waiting on the list to receive an organ deserves to experience the euphoric moment I had the moment I opened my eyes after surgery. As I mentioned earlier, healthcare should be a human experience, rooted in a respect for human life. Let's work together to bring back humanity to healthcare. Thank you for your time and the chance to enrich this conversation. Thank you.
Thank you, Quinn. Our last speaker in this session is Janice Whaley.
So much. My name is Janice Whaley, and I'm the president and CEO of Donor Network West. And I'm glad to have the opportunity to talk about increasing rates of donation and how we can save more lives. I can use our organization as an example of an organization that was in the bottom in almost every category when it came to benchmarking data. And through work, hard work, we were able to move to being one of the top OPOs in the country. And I'll start by saying there are 3 areas of opportunity that I think will help increase the amount of donors. And that is, first of all, keeping the main thing the main thing. There should always be an intensive focus on best practices. The Organ Donation Breakthrough Collaborative that was done probably close to 15 years ago, they have best practices that are known. They provided that to us. They're not outdated. They still work today. And I think for us, we need to move back to looking at how we can use these best practices to help increase donation. The challenge has been implementation and consistency, and also leadership. Leadership is very important in this process, content expertise, and doing the work. It's hard work. It's not a 9-to-5 job. We also have spent a lot of time reinventing the wheel when there's no need to. We need to be engaging. We need to be present. We need to remain in action as we move forward. There is a huge opportunity to continue to build relationships with hospitals, and I'll talk about that a little bit more. There's also an opportunity to increase referrals, increase authorization rates, and getting closer to the donor. The donors are in the hospital. And if we don't have that type of relationship in the hospital, we won't get the call. So we need our staff, the OPO staff, to be present and engaging in the hospital, making sure that we're not missing anything. Very large donor hospitals are pretty busy. And so having a presence of somebody that's inside the hospital, like in-house coordinators, is very helpful and supports the hospital as they are busy, and we can make those calls for them. We can facilitate the donation process for them also as well. The second thing I want to talk about is authorization rates. Race risk adjustment was something that I opposed in my public comment, and I also supported the overall final rule. As Patty mentioned earlier, there's some opportunities for improvement, but overall, it sets the stage for standardization. When it comes to authorization, we cannot change decades of mistrust in minority communities. But what we can do is do a better job at building relationships with these families, spending a lot more time in the collaborative, making sure that, in the community, making sure that people are educated about donation, and making sure that we're focused on different people of color. Everybody's not the same. And so understanding culture and religion are very important. And I have a record of being able to increase in that area. We had a 70% increase in African-American donation alone in my service area. The final thing I want to talk about really quickly is hospital and OPO interface. While we've made some changes to the OPO final rule, there is an opportunity to revise the COPs to reflect what we are being asked to do. There are too many missed referrals when hospitals don't call us. There's interference with first person authorization by hospitals. There's a failure to have 24/7 ability to pronounce death, brain death and cardiac death for DCD donors. And there's a failure to collaborate with OPO experts to support OPO efforts throughout the donation process. I think we also know that there's a failure to recognize OPOs as part of the healthcare system. Again, donors are in the hospital. So if we do not have the support of the hospital, we're not going to be able to convert donors. So I hope that as we move forward, we find ways to develop a process that will allow us to work more closely with the hospitals. And I think it's time for us to make some changes to the current COPs, as they're not going to meet the needs of us in the future. Thank you so much for the time.
Thank you, Janice. Let me now turn to the committee members and ask if there are any clarifying questions that they would like to pose to our speakers. Renee, looks like your hand is up.
Yes, thank you, Ken. I wanted to, several speakers throughout the day have suggested relocating the responsibility for supervising the UNOS and those contracts from HRSA to the Office of the Assistant Secretary of Health. So this is probably at least the third project that I've been on, where the answer seems to be always to move whatever the function is in HHS to the Office of the Assistant Secretary of Health. That's just one office, and I'm just interested, given everything else that official has within their portfolio, I'm curious about why this makes sense, and if that really is possibly a solution to the issue. So I'm just the issues that people have raised. So I'm just curious to people's thoughts about that, because I feel like it could be overburdening that official with responsibilities, and we'll end up in the same place with, perhaps inadequate supervision.
Ken, if I could, or if someone else wants to go first.
No, go ahead, Jerry.
Well, Renee, that's great points. And I can speak as someone who's worked closely with the Assistant Secretary of Health. And as I noted, I think here the unique thing is that
by the way, so.
Yeah, great. No, and the unique thing here is the fact that you have, and this is when we were writing the law and doing our investigation, that then HCFA, now CMS, paid for the entire system. But despite the size of it, I'm sure even today, for them, it was such a small program that they weren't able or willing to invest time in running it day to day. And because of that, we felt it was important to, and because of the mission of really taking this scarce resource where we know people die every day because of insufficient number of donors, where should that oversight lie? And so we felt it really should be as close to the Secretary's office as possible. Now, over time, of course, we were disappointed when they gave it to HRSA, because maybe you probably know, right? It was the agency in HHS for everything else. And so when you were, the other agencies, CDC, I mean, they have great leadership. They're doing things. HRSA does many amazing things, but it's many things. And when we saw how it played out there, we felt that needed a change. But of course, they've done it for a long time, and they have a lot of expertise and leadership there. So I think at this time, you have expertise at HRSA. You have really the real mandate and effort and comes from CMS, because they're paying all the bills, but this isn't something that they would really do. So it just seemed like, I hear you, the Assistant Secretary has so much to do, but given, as we've heard today, there are so many, not only ethical issues, but issues of equity, so many different things that have to be weighed. When we were working on this and trying to set it up, it would have been easy for us, or not easy, but Congress certainly could have said, gee, give it to the most people who would get the best outcomes, or give it to the sickest people who have the shortest time to live. The system we created was sort of, let's get all the stakeholders involved so that they can weigh these issues. There isn't a right right answer. How do you come up with that? And I think that kind of responsibility and the things we're hearing today in terms of the shortcomings of the system could best be resolved at that level and in that office.
So let me just ask you to comment on why not just put it all in CMS?
You know, it's just, again, even at $3 billion, it tends to be almost a rounding error for them. So the question is, would they ever spend the time and effort? I think if they would make this a priority and really do it, they could do a great job. It's just they've never shown the interest in it, right? All of these years, they've still paid the bill. So I feel like they could have always stepped up and said, look, enough, we get it. We're paying the bills. Let's ask more of these OPOs and what we're doing, and they just haven't done it. So that's why I think if you could get the kind of commitment from them and leadership there, and that they would make it a priority. But I can see how they won't, given the scale of the Medicare and Medicaid program and the small piece this represents. Indeed, I don't think it's changed. When we did this, we asked the question. I mean, they didn't even, right? Someone asked if they would provide cost reimbursement. They started doing it. It grew to a $100 million program. When we started investigating, they didn't even know it was really there. They had to go back and say, well, what are we spending? It's just not what they generally do. But I think if you could get them to do it, and they really would put the leadership there, would be worth considering.
I think, Jenny, did you want to make comment? I would just remind people that we're going to lose the connection in about 3 or 4 minutes. So if you have any comments, please make them very succinct.
I'm perfect at succinct. And I just wanted to say that there's a lot of coordination among federal agencies, not just CMS and HRSA, but FDA and CDC. And all of those things have to be thought about. And that's why I think oversight of the OPTN needs to go to the secretarial level.
Okay. Any other comments in this regard?
This is Jennifer Erickson. I would just say again, as a former government official, we should take this opportunity to elevate transplant. If you think about the Biden-Harris administration, they have 4 priorities. This is directly relevant to 2. COVID, which ravages organs, and equity, which we have a huge opportunity to fix, and we've heard about today. The Assistant Secretary has responsibilities for equity, and we need that level of focus.
Kevin, did you have a comment as well?
It's similar to Jennifer's. I just think there's a wonderful opportunity here to do a lot of good, to address some of the issues, rehabilitation, the equity. And then I think also most importantly is incorporating the patient voice in here so they're part of it, right? And represent the community. But I just think it's a great opportunity. I just hope we don't miss out on it. And aim high. Thank you.
Let me ask, Janice, you had a comment, and then I'm going to ask if the committee has any other questions. So very quickly, Janice.
Yeah, thank you. I just wanted to really emphasize the importance of hospitals and OPOs interfacing. I've had a ton of experience where we see the challenges that are faced. And again, donors are in hospitals. So when we have interference with hospitals, we're not able to be successful. So I hope that we can find a way to look at the COPs and make some changes so that there is more of an alignment with what the new metrics, obviously. And I hope that we can find a way to encourage an update on the COPs, which will help us achieve those goals. In the last month, I've had 10 donors that have gone by the wayside because of hospital interference. And I think that it's very important that we align better. And we're trying to build relationships, but I think it needs to be on the level of the conditions of participation, making changes there to help us do what we need to do, and that is to save more lives.
So Michelle, before I go to you, I just want to ask if any committee members have any questions they want to raise as far as clarifying any of the points that have been made today. And Rebecca, help me out here if I'm not seeing everybody.
I don't see any other hands, Ken.
All right, so let me give the last word to Michelle Goodwin.
What COVID does is it exposes our underlying institutional and infrastructural inequalities in our society. This is an urgent and challenging time, but with all challenges come important means for opportunities to be gained. So with the challenges that we've seen because of the pandemic, that are not isolated, but that also inform us about racial inequality, socioeconomic inequality in our society. We can take these as opportunities to do more, to do better, to be more insightful. And I appreciate the opportunity to be with you all today, and thank you for your hard work in this domain. It is greatly appreciated.
So many thanks to all of our speakers. Everyone showed and everyone stayed pretty close to on schedule. And I thank you all for your comments. We're going to lose our connection here momentarily. So we'll go ahead and sign off. To the committee members, we will be reconvening tomorrow and talking further about all of the great input that we've received today. So thank you all for participating. It's very helpful and we really do appreciate it. So with that, we'll call it a wrap.